Hello, good afternoon, everybody. And apologies for this slight delay in starting this. I don't know whether it's the 3 days of the state meeting of the obstetricians and gynecologists plus the Christmas spirit and post-lunch, delays, but sorry about this. We do have people online. So Dr. Hema Devakar is already with us online. Welcome to everybody online as well. I think the director of St. John's has just come, so we welcome.
Good afternoon, everyone. A very warm welcome to all present here. It's an honor to be graced by the presence of today's chief guest, our beloved director, respected Reverend Father Yesudas. On behalf of our hospital and NGOs, Prayas and SOCHARA, a warm welcome to you, sir, for this awareness program. Thank you. The amazing encouragement and unconditional support of our beloved Dean, Dr. George D'Souza, and our Associate Director, College, Reverend Father Charles Davis, have been extraordinary. They have stood with us in every event. We are truly thankful for the trust reposed on us. We warmly welcome you all, sir. It's been a remarkable experience to witness the presence of Dr. Narendra Gupta, founder and director of Prayas, and Dr. Thelma Narayanan from Sochara to witness the passion and commitment they have exhibited to sponsor today's events. Thank you very much for your support, sirs. Thank you. On behalf of St. John's Medical College, NGOs, Prayas, and Sochara, I welcome all dignitaries, professors, students for gracing the occasion. Thank you. I'll hand over to Dr. Sti.
Good afternoon, everyone. I now invite Reverend Father Dr. J. Charles Davis to speak about human dignity and integrity of body parts. Dr. Charles is currently serving as Associate Director at St. John's Medical College, has a doctorate in theology, specialized in bioethics.
My mother womb was my first room. My mother womb was my first restaurant. My mother's womb is a warmer place when I was in cold. My mother's womb is a cooler when I felt wow. Dear dignitaries, our ADC Father Charles, Dr. George, Dr. Thelma, invited guest, and my dear participants. It is really an enriching topic, very helpful topic. That's the reason I have prepared, and I wanted to just express my experiences on this. It is not merely womb or uterus, is not merely an organ. It is physical manifestation of creation, love, and miracle of life itself. The womb is the very place where child is nurtured, where dreams of motherhood are cherished, and the bond between mother and child is established. To remove this sacred space without a justifiable reason can potentially have emotional and psychological and physical consequence of a woman. Why I am so much interested in this topic? I have got an also personal experience. Before I was conceived in the womb of my mother used to tell. She, like other mothers, faced a uterus-related issues that could have led to hysterectomy. However, she made the brave decision to explore alternative options and managed her condition with the natural medicine. They used in the coconut sprout, where the coconuts are coming out. In the tender one, they make a juice and drink. That was a natural remedy in those days. Consequently, I am here today standing before you. If my mother accepted to remove her womb or uterus, I have no chance of exist in this world. Therefore, how important the womb or uterus is for a woman. Emotionally attached, protective, as well as I said, it is the first room, it's the first restaurant and first comfortable zone in our beginning of life. Therefore, I express my deepest gratitude to the organizers for taking the initiative to educate and enlighten us about the crucial aspect of women's health. Really, it close to my heart. And whatever possible, we try to prevent unnecessary hysterectomy. We are with you and we will help you. Thank you and all the best. God bless.
I request Dean to give us some, address the gatherings.
Father Yesudas, our director, Father Charles, associate director, Dr. Thelma, Dr. Gupta, and their delegates. At the outset, welcome to St. John's, and we are delighted to hold this roundtable conference on access to rational care for gynecological morbidities and prevention of unnecessary hysterectomy. It is my personal opinion that this is a much broader topic because rational use, of all the procedures, etc., interventions is something that needs to be taken into account. I'm a pulmonologist and we run a DM program. And every resident who leaves us, when you ask him what he's going to do, he says, I'm going to train in interventional pulmonology. And there are very few interventions that are required in pulmonology. The bulk of your diseases do not require any intervention. And I think the big evil is that because interventions are paid for. It's because interventions are paid for that everyone wants to intervene. And unless we address that issue, I do not think, Supreme Court may rule, anyone may rule. How many people are we going to monitor? So, I think that is the greater problem and the greater evil that needs to be addressed if we have to address also this. So with these few words, I hope that this roundtable conference will address also the broader issue of unnecessary investigations, unnecessary interventions, and unnecessary surgeries. Thank you.
I now invite Reverend Father Dr. J. Charles Davis to speak about human dignity and integrity of body parts. Dr. Charles is currently serving as Associate Director at St. John's Medical College, has a doctorate in theology, specialized in bioethics. He comes with a vast work experience in teaching since 1999 in several national and international educational institutions. His areas of interest include theology and bioethics.
When I finished my PhD on the ethics of human embryonic stem cell research, proposals for a legal framework in India, I realized the insufficiency of those bioethical principles, non-beneficence, beneficence, autonomy, and justice. In fact, these principles by Childress and Beecham are found to be insufficient to address all the bioethical issues today. And that is why I ended up defending the moral status and the dignity of the human embryos that are in the womb, and that they should not be used for research, including the embryonic stem cell research. So I based my argument on the human dignity that precedes everything else, because human dignity is inseparable from the human condition in itself. And I found that the European Union bioethics rightly brought out the three further principles of vulnerability, integrity, and dignity. And I think one of those principles is vital to your conference today, that integrity of the body and bodily parts are important to consider, that human life in itself is dignified, including each and every part that makes the whole as a human body. I like the statement by Pope Leo the 13th. This is wrong here, Paul the 13th. Actually, Leo the 13th, in his document called Rerum Novarum, following the Industrial Revolution, said man precedes the state. In case if we are not comfortable with the word man, we can reformulate as humans precede the state. I would even further go and say that humans precede the religions, humans precede the society, humans precede even norms. Because norms, even Sabbath, what we call in the Bible, and the society and religion, everything else comes, and in fact, they exist for the human being who is inseparable from the human dignity. And that is why in Paschimian theories, we see the fundamental principle of natural and human equal human dignity is the basis for the universal rights and inviolability of every human being. And according to me, I think the human dignity is the root and the human rights are the branches. And the human rights, what we have, are not founded in the air, but they are located in the vital principle called human dignity, which is inseparable from the human body in itself. So this German philosopher Ottfried Hofe, he has made so many beautiful statements like humans develop themselves always as humans, never unto humans. And similarly, this one of the beautiful statements here is the dignity is the highest moral and legal principle, which gives humans an absolute value against all highlighted natures of rationality and freedom. We have the tendency often to locate our human existence or human value or dignity at freedom and rationality, but much more than that. Even where is the rationality? Where does the freedom stand? They can't stand in the air. They are located in a human being who has that value called dignity. In other words, I would always say that we see this principle, do good. Why? Do no harm. Why not? Autonomy. Whose autonomy? Justice. Why should we treat people equally at all? So if you ask those questions to those principles, you will end up in saying that there is some intrinsic dignity in a being called human being. Therefore, we say we have to do good, we should not harm, we should treat them equally, and that the person who has the freedom has to have in some location called human being. So there was a deputation with regard the humanity of Los Indios, the people in Latin America before this conversion business that began. And there was a debate initiated by King Charles I in the Council of Valladolid. These are the two great Dominican friars who debated. Sepulveda, I put it in simple words. Sepulveda argued like this: before we reach the place, those human beings are barbarians. Therefore, we have the right to use even violence to convert them so that they become dignified beings. Immediately shot this Father Las Casas said, no, even before we reach their human beings, we need to treat them equally and use peaceful persuasion to make them dignified Christians. But he had a moral weakness at the end of his argument. In case after the peaceful persuasion, they do not turn to become Christians or dignified beings, then we can call them barbarians. I do not agree to his argument, but there is a beautiful institution in Switzerland named after him, saying that he is the one who initiated the beautiful argument called dignity, but there is a moral weakness in his argument. But in fact, Francis Vittoria is the one who said, no violence, peaceful persuasion. Even after your peaceful persuasion, if those people do not turn to become Christian or dignified beings, they still remain human beings. They have the intrinsic dignity. Historically, philosophically, religiously, as well as legally, we have been defining what human dignity means. I would end up saying in just like this: it is difficult to define what human dignity is. It is not an organ to be discovered in our body. It is not an empirical notion, but without it, we would be unable to answer the simple question, what is wrong with slavery? And we are happy that this is the concept which eradicated slavery from earth. So as every entity, even a pen or a car, whatever we buy, it has a value. We can buy and sell it. But the dignity, which is a human value, it cannot be bought, it cannot be sold. That priceless value, as Immanuel Kant calls it, it is called the priceless dignity. Everything else you can buy and sell, but human life cannot be sold and bought. That is the priceless value called dignity. And to be very short, I like to say explain these three terms. Intrinsic. Intrinsic means that we are biologically human beings. As the moment you are fertilized in the womb of the mother as a human being, you exist as a human being, and biologically that being has a value which is priceless value called dignity, which cannot be taken away. It cannot be given by human beings. It is intrinsic. And the next one, we always see that the moral or social dignity. If someone is doing good work, you praise them. Someone is doing a bad work, you punish them. So that moral dignity is not permanent. It is relative. It can exist, sometimes you can lose. And then inflorescent dignity, which society can attribute to someone, and then that social dignity. For example, you have an office as the head of the institution, or a director, or as a principal. These official things we achieve, but we may lose it tomorrow. So those things are not permanent. Moral dignity, social dignity are not permanent, but intrinsic dignity is biological, and it always exists. So how do I connect this to this women? Women body is sacred. Women body houses the womb. That particular being that is created in the womb as well as the mother, both have that equal intrinsic dignity. It is created like that. If you ask me who gives it, it is not the mother, it is not the father. Every human being is created as such. That's why in Bible, one of the verses, we say that human beings are created in his image and likeness, almost like divine being. And in Hinduism, we say that Atman is Brahman. And like every religion has some sacredness attached to this life called human being. And if that is the thing, we must protect the reproductive organ called womb, because it is where we all begin to exist. We hope that the integrity of the human body and the dignity of human life is respected. Thank you.
Thank you, sir. Uh, I now invite Dr. Narendra Gupta to give us a background and overview of the round table. Dr. Narendra Gupta, a physician by training, has worked extensively at the grassroots level with tribal and other marginalized communities in Western India. For about 3 years, he directed and scaled up a very large volunteer-based program of the government in the state of Rajasthan to promote birth spacing, and earlier for 3 years worked in the central government as an advisor to CAPART for the Ministry of Rural Development of the government. In 2023, he filed a PIL in Supreme Court of India for formulation of guidelines to prevent unnecessary hysterectomies and requested the Ministry of Health and Family Welfare to collect nationwide data on hysterectomies through NFHS 4. Now, Dr. Narendra Gupta works through Prayas, a volunteer organization at Chittorgarh and Center for Health Equity at Jaipur. Welcome, you, sir.
Thank you. Sorry, my throat is bad since morning. I don't have sore throat, but voice has become bad. So it happened essentially yesterday because I ate something which has caused this. So once again, on behalf of the organizing team, since I am also a member of the organizing team, I welcome all the participants of this round table on improving gynecological care to prevent unnecessary hysterectomies. That's the title of the roundtable which we have. And this is the fifth roundtable we are organizing. We have been organizing these roundtables in different states. So the first roundtable was organized for the state of Assam in Guwahati. Afterwards, we organized another in Rajasthan for Rajasthan in Jaipur. The third one we organized in Chandigarh for state of Punjab. Then we organized one in Hyderabad for the state of Telangana, and now we are organizing it here in the state of Karnataka, in Bangalore for the state of Karnataka. So as you could see it from the title itself, we are talking about prevention of unnecessary hysterectomies. We are not talking about prevention of hysterectomies. These are two different things, altogether two different things. We should make a clear difference between. What do we mean by unnecessary hysterectomy? That is an essential thing. So the story goes like this as far as why I am into it. Because I'm not a gynecologist obstetrician. I'm a public health person. But why I'm into it, let me explain. So way back in 2013, what happened that there was a news report and one group of people came to see me and said, so in this particular small area, large number of women have been subjected to hysterectomies in quite a few private hospitals in the vicinity. And the complaints for which they went to these hospitals, their complaints still have not been taken care of. They still experience similar problem. So they feel very cheated because they also spend huge amount of money out of their pocket for which they borrowed money and so on and so forth. And they wanted me to, see whether I could find something more about it. And I realized that after interviewing quite a few of these women, I realized that many of these hysterectomies were done by these doctors as a first line of treatment without even, trying out any other type of treatment which had avoided these hysterectomies. They went there. Directly, the doctor said, okay, let's do your ultrasonography. Soon after the report of ultrasonography came, they said, oh, your uterus has become very bad. It will become further bad. It may become convert into cancer. How many children do you have? I have 3 children. Okay. do you want more children? She said, no. Okay, so get rid of it because that is the best precaution you could take for yourself. That is the way all things were done. And so I found that whole lots of these things were done in a very unethical manner. Absolutely not use any clinical protocol for treatment of the kind of ailments for which they went to these hospitals. And so we decided that let's try to file a PIL, public interest litigation. We wrote to the government asking that these are the kind of things happening. We didn't receive any response from them. And then based on that, we went to the Supreme Court of India. HRL in National Human Rights Law Network was there with us to support it. And we filed a PIL. But then we also realized that maybe this is not the only area where these things have happened. It might have happened in other areas of India as well. So let's try to, gather information whether it's happening in other places or not. At the same time, there were already some news from different newspapers that Government of India launched a program called Rashtriya Swasthya Bima Yojana in 2008. And under that scheme also, lots of claims which RSBY received were of hysterectomies. And they also investigated and found that many of these hysterectomies claims which they received are of the hysterectomies which should not have been done in the first place. That is what they found out. So we had that. And then in 2013, around the same time, we carried out organize a national consultation. I think already that first slide had been shown. A national consultation where we invited people from all over India, those who have conducted research in this area. Small sample studies have been done in different parts, and they also have realized that something similar has been happening. So based on that national consultation, we made a recommendation to Government of India, Ministry of Health and Family Welfare, that why not a national estimate or national prevalence is collected. Means what is the overall prevalence of hysterectomy in the country through National Family Health Survey. And that was a time when the questionnaires for National Family Health Survey were getting drafted. So I wrote to the Health Secretary of that time, Mr. Keshav Desiraju, and within few hours he responded back saying, yes, certainly we'll collect data about the hysterectomy prevalence in India in terms of where in private. And they asked us what kind of questions should be put in for collecting data. So we provided them the questions. These are the questions. So in 2018, we again organized another national consultation where to look into the data of which was collected in NFHS 4, and we found that different states are in different stages of doing prevalence is there of hysterectomy. So based on that, we again recommended to the Government of India that some kind of guidelines are needed to be drafted. In 2019, Government of India constituted a group, organized a big national consultation, and then created a group to draft the guidelines. So these guidelines came from that group. I was also part of it. And then Government of India wrote to different states that these guidelines should be implemented. But health being a state subject, there were always issues like states will agree, not agree, and those kind of things. And incidentally, in 2023, when the new Chief Justice of India took over in 2022, he listed this matter on a quick succession. And within 6 hearings, he decided delivered the final order in which he said that these guidelines which have been drafted by Government of India are binding on every state. So that is how it has all happened. And as you know that somehow there's a misleading information, getting more and more acceptance in our country. And especially, I think that information will be shared by Sapna in her presentation about the trends of prevalence of hysterectomy in India and also in the state of Karnataka, and within that, within districts of Karnataka. So you'll get to know what kind of women are subjected to hysterectomy more than others, with what background, urban, rural, private, and those kind of things. But as we all know, and this issue has even become more interesting now, since last 6-7 days, there's a, you must have been reading in newspapers that menstrual period, should women be given paid leave or not paid leave? That is the debate currently going on. And this has very much to do with this, because a lot of hysterectomies, unnecessary hysterectomies have happened because women think that if we have this periods on a regular basis, then we are out of work for several days if they are a working women, or there are other religious reasons also. We got to know in Telangana that in turmeric fields, women will not enter in turmeric fields if they are menstruating. So all kind of myths are there related to menstruation, and misleading information is this, that if you get your this removed, then you are relieved of problems, all kind of problems. While there are other sides of it, what kind of new emerging evidences are there that there are all kinds of adverse consequences possible. It could trigger not only osteoporosis, but it could trigger diabetes, hypertension, and mental issues are there and all. So that is the kind of a thing. So the idea of holding this roundtable is to, make people more and more aware about that there are these guidelines, especially among obstetrician gynecologist surgeons. Obstetrician gynecologists, women gynecologists are saying it's more of the male gynecologists who do hysterectomies and the surgeons do, rather than do. But then there are alternative treatment options available, which are not so easily accessible at the moment, but they also need to be made accessible. So these are, wide range of issues within this that needs to be discussed. And then how these guidelines, and especially now every hysterectomy to be, if done, has to be reported into a proforma, which has been worked out by Government of India, and it will go in the national portal. But more than this, as I was telling our doctor in morning, in the afternoon, early afternoon, that it's more for yourself, that how you begin to work in the manner, a prescribed protocol or in an ethical manner, so that you become better equipped to deal with the issues and you become more clinically competent to do things, rather than Government of India imposing these kind of guidelines. In one of the states, Punjab, there was a group which was saying, why not we have an act like PCPNDT for unnecessary hysterectomy? So even among doctors now, opinions are divided. Other group was saying, no, why we need an act? And the other was saying, no, unless there is an act, this will not stop. That is the way these kind of debates are going on. So these are all the issues. I'll stop here. Thank you once again for to St. John's for agreeing to co-host this roundtable and do all the preparations for it. And thank you to SOCHARA for agreeing to be part of it. Thank you very much.
Thank you, sir. I now invite Dr. Hema Devakar to enlighten us about the national campaign on preventing unnecessary hysterectomies, a FOXY initiative. Dr. Hema Devakar is a gynecologist, obstetrician, activist, and speaker. She was president of FOXY in 2013 and had the responsibility of heading of the Federation of Obstetric and Gynecology Society of India. She is now the FOXY ambassador for FIGO. She has received the FRCOG Honorary Fellowship by the Royal College of London.
Thank you very much. Ellarigu namaskara. A very good afternoon, ladies and gentlemen. Thanks to Dr. Narendra Gupta for his kind invitation. And you see as how he spoke passionately, his voice, which he said was bad from morning, started clearing up. That's how we are clearing the fog around the very topic that we are here to discuss and debate, having been associated with him and his organization for a decade long. And I'm happy that we are aggressively moving forward to find solutions to do something better, and how can we prevent unnecessary hysterectomies. Well, the very topic itself indicating that something unnecessary is being done lays the foundation for a major factor of trust deficit between OBGYNs and the community themselves, between OBGYNs and the government, between the gynecologists, clinicians who are doing this, with other stakeholders. So there is a gap there in the trust factor between these. So no, they're doing something unnecessary. No, we have to keep a watch on that. That is the kind of mindset where a large community of stakeholders are coming from. Well, I speak on behalf of FOXY, which is our parent organization with 40,000 gynecologists, with a vision of delivering care to every girl, every woman, everywhere, with quality, safety, respect, and dignity. I'm very grateful to the first set of distinguished speakers from the Institute, where this roundtable is being held, who opened up our minds to breaking the silos and also considering the moral and ethical aspects. Well, from FIGO, which is the international organization, 138 countries being fellow members of that, the Department of Preventive Care and Wellness to keep our women well at all times by taking proactive preventive actions, and the Ethics Committee of both FOXY and FIGO are relentlessly working on how to bridge these gaps, how to sensitize and orient our fellow gynecologists. There may be a couple of black sheep, but how in general to change the mindset. So we have many campaigns in FOXY, inclusive of Save the Mothers, Save the Newborns, Save the Girl Child, Beti Bachao, Beti Padhao. Now it is a new campaign on Save the Uterus. There is this Rising India with rising hysterectomies, as you saw on the slide which Narendra ji showed, and also rising cesarean sections on which oftentimes the questions have been asked. So the art of trying to tackle this problem from the FOXY point of view, we in the leadership position actually have expanded the ART into the very three segments belonging to those alphabets. A for advocacy and awareness, R for research and the big data, because in some of the situations, we don't even know why these incidences are happening. And T, the most important prong from FOXY, is the training and capacity building of all levels of healthcare providers. So the alternatives which Dr. Narendra spoke about can be offered seamlessly in every nook and corner. Well, coming to the A part of it, the awareness or the advocacy matters. This is needed definitely for the community. So just one example of how when we went to the city of Teni in interiors of Tamil Nadu, who was on a World Bank project to study how effective the project has been there. So this was a project about the cervical cancer, visual inspection, detection of cervical cancer, and taking action thereafter. Well, some targets were set and the nurses were trained for this visual inspection. But when the primary mapping was done about how many women in this district of Teni should undergo the visual inspection, the alarming fact back then, this I'm speaking about 15 years ago, was a large percentage, half the number of women did not have the cervix at all, because they had already hysterectomized for various reasons as soon as their reproductive career was over. And that was the first shocking revelation which set our minds to something has to be done about this. And thankfully, the organizations which are stepping forward today are giving the same alert all over that yes, some hysterectomies are necessary, but unnecessary hysterectomies should be avoided, which we are completely in sync with. So the equal culprits are both the doctors and the patients themselves, because the demand generation, what we call, from the patient community because of the myths and misconceptions and the mindset and the strong beliefs. Some want it for religious reasons. Some think it's okay to get rid of my uterus because it's finished its job. That is the mindset that they've grown with. Many consider menstrual cycles as their, a curse on them. And they are absolutely unaware of the fact what happens next if the hysterectomies are unnecessary and then done at an early age. Well, now there are initiatives taken by our own organization, not only in the camp setting where Nari Swasthya Pehal is the movement where the early cancer detection camps, etc., to tell about the wellness and also address particularly the 35 plus age groups who are likely to be in this bracket of being misinformed and subjected to unnecessary hysterectomy, to tell them about what menopause is all about. And there are several IT community and the startups who have come out with some fantastic apps which are now being translated into many Indian languages, where the connect between the women and the healthcare providers, the Swasthya Sakhis, as we call them, the primary level providers who are from their own community, trained by us, certified by Health Sector Skill Council, and empowered to have the correct awareness and knowledge about what if and what if not. And they are the intervening catalysts to bridge this gap about better understanding, so that in a rushed manner, without recognizing what she's going through, the women would subject themselves to unnecessary hysterectomies. They're empowered to ask some leading questions. They're empowered to seek more opinions, even on the digital platform, where they can get the best of the advice that they could. So we are harnessing the digital technology as well to do better than what we have done before. The same goes for the association of FOXY with the IMS, or Indian Menopausal Society, where certification courses are being instituted through the digital platform, with the simulations and the skill development and skill building for the peer group and the doctors, so that when they offer the alternatives beyond the hysterectomies to save the uterus, they are well equipped and they're confident and competent to offer these as alternatives. So this is about awareness both to the community and the peer group, so that the correct kind of information and awareness and the advocacy is also to the policymakers and the watchdogs of the society, civil society, and the activists, so that we are all sharing a common concern on a common platform. We understand where the gaps could be. R is the research or the big data. You will be very, very surprised to know that many of the doctors are playing defensive, playing safe. Oh, this woman cannot be brought back to the setting for a follow-up, so let's just get rid of her uterus and the cervix. That is also the mindset of the doctors, as much as it is from the husband, the family, or the women themselves. So what is really happening there? Even if we want to do an opportunistic testing, the HPV testing or the pap smear testing, there is the lack of awareness, as well as the expertise or the hub and spoke network of the laboratories which can offer these tests in smaller settings, sub-centers, primary health centers, where this could easily be done, especially with the new HPV. Why I'm speaking about HPV and cervical cancer? This is one of the dreaded fear, because they are to some extent aware that there is no symptom of cervical cancer. It is the morbidity and mortality is dismal. It's often detected late. So before anything happens, better get rid of the cervix and the uterus, even if they don't have any issues with the uterus and the bleeding per se. So these are the common things going on. What is the knowledge? What is the attitude? What are the practices, both of different communities, because they're likely to be different in the whole of our country, and the cultural shift and background, which makes them think in the way that they are, compared to what are the knowledge, attitudes, and practices of the doctor, medical care provider community themselves. So this is rich data. This is big data, which is at the moment being captured by the FOXY research. community and can you hear me? Because Sapna, can you make sure you hear me? Because
Yes, yes, I
yeah,
can hear you perfectly.
on one block there is a mute icon. So I think, yeah, thank you. So the research has thrown more light as to the root cause of why easily the doctors offer and very easily the women agree to this. So those gaps also are very, very important to recognize and build the trends which will help us to actually solve the problems that are now on our plate. Lastly, and most importantly, the training and the capacity building. The training of the community volunteers or Swasthya Sakhis who are telling the right things, and even the HPV vaccination campaign and the screen the mother, vaccinate the daughter, etc., so that menace is lost. And the fact that menorrhagia and anemia, like two sides of the same coin. So those who have heavy bleeding, before they deteriorate, they must also get their anemia corrected. And the fact that there are many alternatives which the community should ask the healthcare providers and doctors. All of these, the Swasthya Sakhis, which are feet on street warriors for us, are disseminating in the community for better awareness. And the frontline healthcare providers in small towns and cities who know their limitations of what they can offer, whether it is a medical treatment which gets the primary problem on hold, whether it is the insertion of intrauterine contraceptive device with a hormone, the LNG IUCD, which is now easily available, and they should be empowered, and we should build their competence to at least offer this much, because this does not require a hi-fi setup. It can be done even in the primary centers, and the follow-up can easily, seamlessly be done by the video consultation through a specialist in any nook and corner of the country. That's a very, very good alternative. Hysteroscopy, N number of centers have been established. Weekend programs are happening on hysteroscopic resection of the submucous fibroids, for example, which may be like a dust particle in your eye, making your eye cry all the time, making the womb cry all the time with the bleeding. Very, very easy solution to remove that fibroid alone rather than removing a whole uterus and the cervix in the fear that something else may happen in future. And lastly, the alternatives in the variety of other processes like hysteroscopic resection of the endometrium, many other alternative methods which can prevent the complications with preserving the uterus. So that is the aim. And in a percentage of cases, we have noticed in the last decade, out of 10, 8 can be managed by alternatives. 2 will still need the hysterectomies. As Narendra ji said, it is the necessary hysterectomies which we should do, and not the 8 others which are unnecessary or which have alternative therapy or which have been advised because either the doctor or the patients have no patience to preserve the uterus. Of course, another huge area of gap is the follow-up. There are many who fear that they cannot follow up on time. They come from hard to reach places, etc. But ladies and gentlemen, let me end with a hope that technology is here with us. Telemedicine guidelines have been laid down. Even our rural Arogya Kendras, which we have established in public-private partnership, every single day, the rural women there communicate with our doctors on the video consultation. Even speaking to them is so reassuring. It lets them wait. It lets them think of what, because it's out of fear that many of them subject themselves to whatever they have been told to, or whatever they have understood of what has been told. So if we tie up the healthcare with technology, I think that's a big leap forward. If we tie up the technology for the big data, we will figure out what needs to be done in this great country in various pockets, so that some things which we have never thought of may come into picture then, and then we may be able to do better than what we are doing. And also in a TikTok kind of a video, social media is so rampantly popular now. So we have to be in that space, whether it's celebrities, whether it's religious leaders, whether it's ourselves as healthcare providers, we need to give them one-liners, a 10-second video to make them understand that, hey, at least, you know, you have the right to ask, you ask, or whatever. So I think there is a whole ART, which I just mentioned. There is an immense scope to do better than what we're already doing. Of course, we need to sensitize and orient the entire community of OBGYN specialists and maybe some surgeons who are doing the hysterectomies to submit the data, to document their justification of why they have done. And slowly and steadily, I think we should hope to move forward to do what is actually necessary. And we do hope sooner rather than later, this entire caption of unnecessary hysterectomies should fade away in the background and become a non-issue. Once again, to Narendra, Gupta, Sapna, who couldn't get in touch with me earlier, but somehow we have connected today with this enlightened audience and the people who are really passionate about doing the right things for the girls and women. Let's not fail them by not giving them the best we can. And I really do believe that together we can and together we will. Namaskar.
No, I think I'm audible, huh?
Yes, Narendra ji.
Hello, Hema. Dr. Sudha here from Assam.
Yeah, hello.
I have a few aspects to discuss here with you.
Please.
Firstly, you were talking about counseling a woman on availability of alternate methods like LNG, IUCD. I think most of our women who belong, at least those who come to the government setup, they do not have accessibility for LNG, IUCD. So we have to remember that when we are counseling. Even if we offer, they always think of the cost involved in using LNG, IUCD, though it is found to be effective. So middle
Can I
class
quickly
and upper
respond to
middle
that?
only can afford it.
Yeah. Can I quickly respond to that? Because when we bought in the injectable iron to get rid of the severe and moderately severe anemia, the same questions were raised that it's not available easily in the government setups and the cost is. So we have to be advocates for that as well, because we have to advocate for the solutions. And if we raise the noise levels, loud enough, I'm sure that they will be made available and the cost will also come down. There are two different segregations, what the private practitioners can get and what the government settings can get. And if this is possible, seriously, this is one of the tested methods that the private practitioners do use to avoid hysterectomies. Initially, the companies were saying that, madam, the doctors are not ready to use this because it's very effective and they will lose a case for surgery and intervention. Sir spoke about that it's paid, so then many want to do intervention. So like that, many wants to do hysterectomy, sir. So, but slowly, steadily, the scenario has changed because the women themselves who are educated have read about these options and they come and ask us. So now, if you see the market sales of that in the private sector, it is pretty much high. And it has saved many a uterus. So seriously, this is a point well taken. We will have to campaign for this and get the prices down and get the availability, because unless the government is on board, unless a large section of our women are addressed, this is not going to only with the private practitioner for little money doing this and that, and 1,000 questions they're asked. So they're also very careful now. But so this we will, that is something which we're already trying in the background. But if we escalate this through platforms like these, I think sooner rather than later, we will get there.
Yeah,
And there's a Dr. Rupali Roy from the government is going to speak. I think this question definitely can
Yeah,
be
yeah,
addressed.
because the management protocols and the management differs in what setup the women is. It
Right.
definitely alters.
Right.
Yes.
We are not even lucky to get a vaccine free of cost from the government, which we are aggressively.
Yeah, so we can
trying.
address this question to Dr.
So
Rupali
yeah,
Roy.
yeah,
She'll
that
speak.
we have to address through Fox. We see to it that we do it, sir.
Certainly.
And the second one is availability of hysteroscopy at all centers. The same holds good even for availability
Absolutely.
of hysteroscopy and resections. Then third part I wanted to ask is now when we are counseling in government setup, because I come from a government setup from a government medical college,
So
I'm
request
requesting
you to put these questions to Dr. Rupali.
on mail. On mail. Yes, sir, I will be doing it. Recently, we had one national meet, including Government of India on safe abortion care. We had organized it in Hassan. I just want to know role of counseling, whether we can do on teleconferencing if the woman is sitting at home. So
Yeah.
that would be more effective because where there is high load setting, where women seek BPL services. I think teleconferencing, can it be done? And counseling be done effectively.
Rupa,
To the
you have to
women
say it
at
should be done.
home.
It should be done, and we have to promote this because we have for our rural women a program called Samvada. And in Samvada program, it's different for the youth because their problems are different. And Samvada program for 35 plus women is totally different. And then n number of queries on menopausal, perimenopausal issues where one-to-one the doctors don't have time to talk, and they, it's a whole
Yeah, that is where we
yeah,
have
dialogue which
overcome
we have to
that
spend.
on teleconferencing. There is telemedicine available. We have done it.
Madam, can
Yes.
I
Sir, I'll talk to her in person. I was just talking to, because
Madam,
she is
can-
effective at Foxy level and Figo level. So I was discussing with
Madam,
her.
can I answer your question?
Yeah, yeah.
Sir, madam, in case otherwise we can request this thing government to provide a trained counselor so that they can do the one-to-one counseling, and then they can give what are the alternative treatments are available, and those things they can be informed.
Yeah.
And doctors
think
also
I-
can do because the government hospital setup they are very busy, so they cannot do. At least initial counseling has to be done from the treating doctor. Then that the trained counselors they can do.
Consent forms should also document what are the other
That they will tell you.
conservative managements which have been used and how they failed and what are the dates it was done. All that might have to be included, which are not currently being done. Because I have done even audit for 1,100 hysterectomies which were done unnecessary at some place in Karnataka. We have done that audit for government, and lot of inquiries we had to attend. Not me, I had conducted an inquiry. So that is the scene outside. In a private setup, it is okay. Like everything, we are aware of what all to do, but in government setups, it is a little difficult to implement these. Maybe audits have to be analyzed. Then we'll come to know how effective we have followed all these protocols when we are going ahead with hysterectomy in women who are less than 40. Thank you.
Thank you, ma'am. I would now like to invite Dr. Rupali Roy, Assistant DGHS, Delhi, to tell us about the national guidelines for preventing unnecessary hysterectomies. This will be followed by a short question and answer round.
Thank you so much. Namaste.
Good afternoon, all. Am I audible?
Yes.
Okay, thank you. Thank you. Thank you so much for inviting me for this roundtable on access to rational treatment for gynecological morbidities and prevention of unnecessary hysterectomies in Karnataka. Thank you, Prayas, UNFPA, SOCHARA, and other NGOs, and Foxy. The previous talks given by speaker, Dr. Narendra Gupta, Dr. Hema Divakar, Madam. It's made easier for me because they had already set up the platform. Now I would like to request to share my presentation, or shall I share the presentation?
I think they'll be doing it for you.
Okay. Okay. Next, please. As the Dr. Narendra Gupta sir already informed us the background behind these developing guidelines and issues regarding how these issues raised. So, in addition to this background, I would also like to inform all participants here that in 2019 there was an assurance also which was we answered in by this ministry regarding unnecessary hysterectomy, and that parliament question also raised because of the NFSS data, wherein it showed that the percentage of hysterectomies are much higher in few states, and mostly in the private setup. That was mentioned in that parliament question. So, sir already informed us, like in 2023, Supreme Court response to the PIL and mandated the implementation of MoHFW guideline. A few states have a very high percentage of hysterectomy, like Andhra Pradesh, Telangana. Telangana, you already had a roundtable meeting. And then in Karnataka, as per NFSS 5 data, which was conducted in 2019 and 21, the percentage of hysterectomy was 3.4. Next slide, please. So the purpose of the guidelines was to show the guidance, measure the address the unnecessary hysterectomy at facility level, strategies for monitoring and community awareness generation activities, clinical guideline on common condition that have emerged an indicator for hysterectomy, and definitely for the at ministry level, the most important is doing the auditing and the data collection forms, and from the data collection forms we come to know the indication and the definitely the other demographic profile like age of the person. So from that, especially as in my previous speaker also mentioned about less than 40 years. So as per the guideline, like among all the hysterectomy where the age group is less than 40 years, audit is must. It shall be done by the state. Next slide. The programmatic guidance is it has to be done some intervention at primary level, secondary level, and tertiary level. And our the various partner who are present there, they have already attended few meetings in the ministry also, and they know we are working towards this. Then the capacity strengthening of secondary and primary level services providers, referral, that is very important, and then awareness generation. We already formed a national level subcommittee for effective IC method, developing IC material, which will help us further for awareness generation, and then ensuring appropriate use of health insurance as and Dr. Narendra Gupta sir also told that introducing of RSVI is the important one of the important factor also, which may have some reason for which the number of unnecessary hysterectomy is being increased. Next slide, please. So as per the guideline, it is actually 3-tiered monitoring structure. At national level, we already formed a national monitoring committee wherein the representative from directorate, then non-communicable disease, maternal health section are present. And then at the state level, there should be a state monitoring committee for hysterectomy, and then further district level district health monitoring committee. The first meeting for national monitoring committee already been held, and the TOR is to the national monitoring committee is supposed to be meet in every 6 months to see the number of hysterectomy are being done at the various state level. Next slide, please. And also to guides the states. As I mentioned, the National Hysterectomy Committee, the official are from Directorate, NCD, ICMR, and Maternal Health Section, and it is under the chairmanship of ASMD, National Health Mission. And then the role, as I told, we have the National Committee is supposed to meet every 6 months. They will review the all data. They will are responsible for organizing training, sensitization session, both public and private sector. And I'm thanks to Prayas and other organization here who are helping us, because this we will consider as a part of some sensitization session, which will help us further to sensitize our all doctors and other staffs. Then, as I mentioned, the subcommittee is working for developing IEC materials for alternative treatments and clinical protocols. Next slide, please. State Hysterectomy Monitoring Committee is supposed to be formed under the chairmanship of Principal Secretary, with members from State level Director of Public Health, NCD, RCH, FOXY representative, development partners. And that State Hysterectomy Monitoring Committee also supposed to meet once in every 6 months to review the hysterectomy data at district level. And the state, as Dr. Narendra Gupta also said, and we also face a problem while implementing something at state level, because health is a state subject. We fully dependent on state. And as on date, as per information available with this directorate, only we have received communication from official communication from state law, UP. They have from the State Hysterectomy Monitoring Committee. But from other states, including Karnataka, we haven't received any communication whether they have formed the State Hysterectomy Monitoring Committee or not. Although we have sent many reminders from secretaries are recently, also the file is under submission for another reminder from ASMD. So if the representative from state Karnataka is there, I would like to request you please share that data also, and also please inform us whether you have formed State Hysterectomy Monitoring Committee or not. Next slide. And then it is the responsibility of the state to find out whether District Hysterectomy Monitoring Committee is formed or not. That's supposed to be formed under the chairmanship of District CMO, with the members from NCD Nodal Officer, District RCS Nodal Officer, FOXY member, and development partners. They're supposed to meet and ensure line listing, and then also do monthly audit of cases under their jurisdiction. Then they are also responsible for organizing trainings and doing sensitization session, both public and private sectors. Next slide, please. This is the format which we have shared with all states and UTs along with the guideline. And from this directorate, we have shared the Excel sheet so that it become easier for the states and UTs to share the data. Till date, we are around from 5-6 states we have received, but still we're supposed to received data from around 30 states and UTs. Next slide, please. This is the clinical protocols which my previous speaker also highlighted. Like common indication, though they are there for doing the hysterectomy. Still, I personally have an objection, like why we are calling it unnecessary hysterectomy. Unnecessary word I find is very like. I can't actually accept this word, but still I know there must be some, because our expert are there from obs and gynae department, and they know there are some indication where hysterectomy is required, but we have to like focus on other treatment modalities where maybe most of the cases we may avoid hysterectomy. Next slide, please. For awareness generation, one of the positive part for hysterectomy I feel, because this is done at specialty based, so we should not miss any opportunity wherever we get the chance to interact those women for while providing treatment. So there is a scope for doing, as one of the doctors was mentioning, counseling. I fully agree with ma'am, because one-to-one for this type of cases we required one-to-one counseling. So whenever we got the opportunity, we should counsel them for alternate treatment, for medical treatment, so that we may inform them about other treatment, and then the advantage and disadvantage of for doing like hysterectomy and not doing hysterectomy. So all information there's supposed to be required, some informed methods or some counseling, better counseling, giving some more time while dealing such patients. So as a doctor, as a professional, and other NGOs also help us for generate awareness, not in the facility, even while they are doing the field visit also. So this should be our focus, to inform them all about all alternative treatments and other aspects of this hysterectomy. Next slide. So main focus now, current status is state has to form the state monitoring committee, and then subcommittee we already formed, and our committee is on work for developing IEC material and alternative treatment. Though alternative treatment and IEC also is there in the existing guidelines, but we are further working on it for refining the thing. Then we will maybe that data will be analyzed, and we have requested ICMR to support us once we'll get information. And then definitely NFSS and LAC, that is a longitudinal aging study which was done in elderly patient above 45 years. They are also they are doing the data collection regarding hysterectomy. It will be continued, and then definitely consultation for feedback on guidelines with the support of various organizations we will be doing. Next slide, please. Thank you. And I hope, because this kind of work is required public-private partnership, and without the support of various stakeholders, it is not possible. We are at present is very early stage. We have to work go there is lots of work has to be done by all the stakeholders. So long way to go. Thank you.
Hello, Doctor. I'm Chetna Belgare. I'm from South First News website. My question is, when was this committee formed, national level committee? And when was the first meeting held?
I have the data. It's almost 8-9 months now, ma'am. Exact date I may share you. You may write to me. I can share even in fact the date of the meeting also and the committee order also.
Okay, sure.
Yeah.
Excuse me, madam, do you have any data? Do you have any data that which states are following this guidelines?
Sir, can you repeat? I didn't get you.
Do you have any idea how many states are following these guidelines? Set
Okay,
by
sir.
the
As
yeah.
I mentioned, around 5-6 states have share the data. So we assume those states are working on it, and we received about formation of state level committee from UP. So as per my information, like 5-6 states are following this, but as this group is doing round table meeting, already been done in 5 states, and but that's why through this like platform we are requesting the states, like for example the states Karnataka. We haven't received data from Karnataka. We are not aware whether the state level committee is formed or not. So the group is there, all relevant stakeholders there. So I would like to request you, if you already formed, please inform us or also share the data.
Okay, thank you.
Dr. Gopal Dabde, you want to ask or should I read your question?
Thank you very much. Can you hear me? Am I audible? Hello? Can you hear me?
Yes,
I can hear you. I can hear you.
Okay. Thank you very much, madam. Thank you very much, Dr. Rupali Roy, for your very wonderful presentation, madam. I was just wondering what are the indications for hysterectomy? I mean, one of you even said that fibroids and DUB and also acute infections, all this constitutes an indication for hysterectomy. Is it so? And if so, what are the guidelines that have been issued for the indications? Thank you.
Sir, see, here we already formed a committee with the expert. I am a public health person. So the exact indication will be like, sir, if you have read our guideline, in that guideline, the various indication is already there. And as I informed, we already working for alternative treatment with indication. So national level subcommittee is formed. So once they will finalize the guideline, we will share with the all stakeholder and states.
No, but in your slide you shared.
Yes, sir. It was mentioned in our guidelines, sir. If that's why our subcommittee is working on it further to refine it and to make it exclusive, so that we can it should not be the like that the national level guideline is issued and all the indication are not been included. So the where hysterectomy should be done, where it should alternative treatment is possible, that will be the obstetric and gynecological expert will be the best person to answer, sir.
No, I'm only concerned that your PowerPoint may sometimes mislead people and the consumers and the gynecologists, saying that very simple conditions which really don't need hysterectomy. You have put them as indications for hysterectomy. I mean, this can give a very wrong message, madam. I'm sorry, but this needs this. Please
Okay,
correct that.
sir, we will take care. Next time we'll be careful to show this slide. But definitely we are working on this, and our expert would like to form some chart kind of thing so that it become easy for the doctor also, where it like what treatment, if the condition is like that, what treatment should be given. If the condition is not that, where hysterectomy should be done, like that. We are working on that, sir.
Already there are so many misconceptions about hysterectomy, madam. And I think your guidelines should show a flow chart where
Yes.
exactly it is indicated and what are the things.
Yes, sir. Exactly, sir. We are wanting like that only. Like we will be forming some chart kind of thing.
Thank you.
Yeah.
Thank you, ma'am.
Okay.
I will now call upon Dr. Shashikala Karan, Professor and HOD Department of OBG, St. John's Medical College and Hospital, to speak on Preserve the Uterus, Awareness and Improving Gynecological Care Prevention and Unnecessary Hysterectomies.
Good afternoon, everyone. I'm Dr. Shashikala from St. John's Medical College, and I'm a professor and HOD here. And I'm talking about the preserve the uterus. Preserve the uterus, awareness and improving the gynecological care and prevention of unnecessary hysterectomies. Health of a woman is paramount to ensure the health of communities and the nation. Awareness is the key to initiate informed decision making when it comes to women's health. Because of this awareness campaign, the Preserve the Uterus campaign has launched nationwide on 20th April 2022 by one of the pharmaceutical company in partnership with Foxy and the Integrated Health and Wellbeing Council, that is a non-profit NGO, and the aim of that campaign was aim to raise the awareness among the women and also sensitize and educate healthcare practitioners through the knowledge sharing and upskilling workshop across the country via virtual and physical meetings. It also helped to women to understand alternative treatment for minor gynecological issues, so that she can take a decision on the whether she wants to undergo hysterectomies or she can go for a alternative treatment. So now we are discussing about that unnecessary hysterectomies. So we want to know that what is the reasons for unnecessary hysterectomies where the patients are going for a hysterectomy. So actually when they have done the survey shows rural people are the most vulnerable for these things. There are so many reasons, like Indian women, especially those living in small towns and villages, have a poor knowledge of their reproductive health. They may not come for a regular follow-up, regular checkup, and they may not take care of themselves. Even if they have any other problems, menstrual problems or anything, they'll come in late. So in those patients, by the time they reach the hospital, it will be late. So that time they may have to go, they have to undergo hysterectomy. But in case if we take care of all these things, we may treat in time and then we can avoid the unnecessary hysterectomies. And fear of cancer. The fear of cancer, this is incorporated by a treating doctor or friends or the relatives. They will have they'll come to the doctors with a mindset of thinking that in case if she doesn't undergo a hysterectomy, she may develop or she might develop cancer by under 5 or 10 years. So that's why they will come and she'll ask that do the hysterectomy so that I will be free of cancer. So that's why in those patients also we have to counsel and then we have to make her understand that benign conditions may not cause the cancers. Abnormal uterine bleeding. Whenever the patient has any abnormal uterine bleeding, can be treated by alternative methods. The hysterectomy is not the first choice of treatment. So in case if the patient comes with any abnormal uterine bleeding, we have, as a doctor, we have to tell her that what are the alternative methods. In case if it is not controlled, then only she has to go for a hysterectomy. And public health insurance. What are the public health insurance? It is the study done in Andhra Pradesh. They have found that when the government has issued the insurance to the poor people to get a treatment from the private side, so that time they found that there is a sudden increase in the hysterectomy numbers. And then again that NGO, they came to know that, and then they have done the survey, and they came to know that in a particular, that too in a private sectors, there is a sudden increase in the hysterectomy rates, that too in a younger age group around 30 to 40. So that time they have taken this issue to the government, and the government has abolished that public health insurance. And also we also have seen in our OPDs and all, sometimes the patients comes with the insurance policy. Anyway, that insurance is there, you do the hysterectomy. That type of attitude also the patients also they have. For those patients also we have to counsel and we have to tell them that what are the hysterectomy is not an ultimate treatment. And relate to all somatic symptoms to the uterus. Compared to all, any patients, if they have a chest pain, backache, or any tiredness, or even in a headache, all symptoms they relate to the uterus. So that time they say that no, only because of the uterus is there, I'm having all the problems. So just to do the hysterectomy, so I'll be relieved from these symptoms. So in those patients also we have to do the counseling. And RMP and registered medical practitioner are general practitioners. So these are the patients we usually see in the private practice. So the RMP or a GP, they will come with the patients, or they will call up and they say that, doctor, I have a patient, she is ready for a hysterectomy. So, and I have also counseled and patient is agreed. So even because that the RMP or a GP, that is a primary treating doctor, the patients believes those doctors. Whatever they say is that is the ultimate. Even if we say they may not be agree for alternative treatment. So in those patients, those doctors also, we have to empower them with the alternative treatment, and we have to create awareness in their level also. Other reasons are the lack of integrated, broad-minded approach among the doctors. See, even we doctors also, that in case if the patient comes from the rural area or she looks poor, why she has to give? Why we have to give her alternative medicines? Why can't we do the hysterectomy? That will be the permanent thing. So that's why we ourselves will not give any alternative treatment for her, or we will not tell her any alternative treatments. So we'll tell that when okay, you have these problems, better to undergo hysterectomy. So that mindset has to be changed in the doctors. And white discharge PV. This is the commonest symptoms the patients may come with, and then she say that if because of the white discharge, she is having a tiredness, not able to work, backache, abdominal pain, all these things. She say that won't be in case, and also the fear of cancer. So she says that in case if all this, because of the uterus, I am having all these things, and also because of this white discharge, it is not coming under control. So better to do the hysterectomy. But here also we have to tell her that that is not the reason for that, and it can be cured if it is due to infective origins. And attitude towards the women's health. As all we know that in India, that women health is always not in priority. So at home also, if the patient has any problems, like if the patient has a menstrual problems, nobody will bother. So she herself, and then she is also like hierarchy. She will be in a rural places. They will be having a fear to talk about the maybe because of the taboo. They will not be talk about the menstruations and all. They may not tell about the menstrual problems to the husband or to the relatives. So they will suffer, and by the time they'll reach the hospital, they will be in a maybe severely anemic, or maybe in case if they're due to other problems, endometrial hyperplasia or anything, they may be we have to do the hysterectomy for those patients. Because of that, this we change the attitude at home through the grassroots like ANMs and other community health people. If they go and change the attitude in the community level, that also can change, and then we can prevent the unnecessary hysterectomies. And also taboo. Taboo is that if the patient, they all women think that if you have a after the childbirth, this uterus, no need of having a uterus. If any problem, why you have to suffer with all these things? So better to go for a hysterectomy. And lack of support from the family for the follow-up. Even though the girl or the lady wants to go for an alternative method, in those patients, if for example, if you take one pap smear, if it comes as a LSIL or CAN2, if she is not willing for a hysterectomy, but patient has to come for the follow-up after the treatment. So sometimes maybe she has to come recurrent follow-up. That time the patient's relatives, they say that why because of the I have to, I'm spending so much of money on her and I have to come so many times. So instead of that, you do the hysterectomy. So that type of if there lack of support, that also was one of the reason for her to go for unnecessary hysterectomies. So other than that, the most common indication for hysterectomy, the most common surgery in women after cesarean delivery in India is that hysterectomy. So usually the fibroid, heavy menstrual bleeding, cervical dysplasia, pelvic inflammatory disease, and endometrial hyperplasia, prolapsed uterus, and cervical cancer. These are the conditions without only except that heavy menstrual bleeding, if it is not controlled with the hormones or oral medications, and with the LNG IUCD. This pelvic inflammatory disease, if it is a chronic PID, if it is not responding to the treatment, these are the indications for a hysterectomies. Prolapse uterus, first degree or the second degree, we can go for in a younger patients, we can go for a conservative surgeries. But in case if the patient has a third degree prolapse, if it is not willing, then we can go for a sling. Not willing for a hysterectomy, we can go for a sling surgeries. If the patient is willing, then only those patients third degree, those patients we can associated with the vaginal prolapse, histocele or rectocele, those patients should undergo hysterectomy. So what are the alternative treatment is available for other than the hysterectomies? The healthcare practitioners in Western countries, the number of hysterectomies have come down. That is because of healthcare practitioners actively favoring more conservative approaches. The alternative methods for treatment to hysterectomy are for excessive menstrual bleeding, oral tablet, hormonal or non-hormonal we can give, and hormonal injections can be given, and LNG IUCD can be used. And for the fibroid, removal of the fibroid, that is all myomectomy. And also in case if the facilities are available, we can go send for uterine artery embolizations. And if the patient has an abnormal pap smear, patient can be go for a conservative treatment. But only thing is that she has to come for a regular follow-up. And PID, acute PID or a chronic PID, we have to give antibiotic treatment. If it is not responding, then only patient has to be subjected for hysterectomy. So the patients, they come that hysterectomy that will not have it's a simple and doesn't have any complications. So that hidden harms of the hysterectomy, that is surgery is often accompanied by removal of ovaries to reduce the risk of ovarian cancer. So in those patients, usually they have vaginal burning, increased urinary frequency, and in those patients, because of the removal of the ovaries, early onset of the menopause. Even then, even if you are not removing the ovaries also, if we do the hysterectomy, that also they say that the study shows that it accelerates the menopause. Women who have undergone hysterectomy tend to have increased incidence of heart disease. There is an increase in the heart failure, threefold increase in the heart disease, and may also show symptoms of osteoporosis in early age. And also it shows some signs of depressions, and few of them they showed metabolic disorders, and also they have found that there is a dementia also because of the removal of the ovaries in these patients. So now we'll come to that awareness. So awareness can be in the field level, and means like on the patient level or in the doctor's level and at the level of the public. So in the field level, we can go through the like Dr. Hema Divakar has told that ANM, Anganwadi workers, ASHA workers, these all are, we have to create awareness and we have to empower them that what are the methods, treatment methods are available alternative to the hysterectomy. And these people, they have they will go and educate the community in the villages, and they can empower these patients to take a decision on what medication they want to go for hysterectomy or a alternative treatment. And then they're introducing the screening program, like screening program for cancer screening program, so that they can, in case if there is it's a benign conditions, we can counsel the patients to go for a alternative treatment. In otherwise, if it is CN3 or a dysplasia, then patient gets go for a hysterectomy. Peer group educations, that is very important, because if the patient has one of the if in a community, if the patients are using a LNG IUCD and or who has gone the hysterectomy, undergone hysterectomy, they can, in the that ANMs or Anganwadi people or doctors themselves, they can create a peer group so that they will do the they will to share their knowledge, share their experiences in case if it's a LNG study, whether how it is useful, how they are doing it, and then whether well, that means like it's a good alternative for the hysterectomy. But at the same time, hysterectomy people undergone a hysterectomy in early age group, they can tell that what is their problems, and so that because of these group discussions, patients can take a decision on that what medications or what treatment she wants. And family health physician, this is one of the family health and it also helps for the improvement in the menstrual hygiene in adolescent. At the same time, this same girl, she can go to and tell her mother what is menstrual hygiene, what she can treat, and then she can help her to take a decisions on the whether to go for a hospital or whether to take a treatment or whether she can manage at home. Inform women at consequences of the hysterectomy. So as I already told that what are the complications which are associated with hysterectomy, we have to tell before the going for a hysterectomy, and educate women in the local language. So if you're telling in the local language, I think she is better understand, and then she can take a decision. Then it comes to that doctor's level. So doctors also we have to change our attitude that only it means like if the patient comes with some problem means like we have to do the hysterectomy. So it's not. So we have to train the doctors like continuous medical educations regarding the what are the new drugs are available, what are the other hysteroscopy training or a laparoscopy hysteroscopy training or a TCRE, all these things that we can help for them to go for to practice alternative methods. And uterine preserving surgeries, like especially in the mainly in the So uterine prolapse, that in case if there is any second degree prolapse or uterine elongation, early age group, that time patient can go for a sling procedures or a Fothergill operations. Physiotherapy, if the patient has come with chronic pain, chronic pelvic pain, or first degree or a second degree prolapse, those type of patients, we can tell them to go for a physiotherapy, pelvic floor exercises that may help to cure the disease. In prolapse, it may not cure, but at least it will not increase. So implementation or follow guidelines and manage accordingly. So in the, just one more slide. The training towards less invasive, implementation or follow guidelines and manage accordingly. And we have to train the doctors to follow the latest guidelines and manage accordingly. And training towards less invasive methods than indications for methods than the indication for hysterectomy. Means like when you are training them, that we have to tell them that what are the minimally excessive surgeries are there and not the hysterectomy. And appoint trained counselor so that the initial counseling that can be done by the counselor, but treating doctors, and then later one-to-one counseling can be done to inform all the what are the alternative methods available for the other than the hysterectomy. And attitude of the doctors, as I told earlier, they have to change. And patients, again, that educate the patient regarding the alternative medications. Effective counseling helps her to make a choice, and ask her to come for a regular health checkup and educate the family members so that they will bring the patients in time and for the follow-up. Public awareness, that is public awareness already there are so much they have told. And now the public-private partnership in addressing complex health changes in women's health like heavy menstrual bleeding and giving an overview of the path-breaking work that has been doing in the realm of women's health. That is that Preserve the Uterus campaign, and also now that Dr. Narendra Gupta at Prayas and SOCHARA also doing the awareness program, bring down these unnecessary hysterectomies. So in conclusions, uterus is not a vestigial organ once family is complete. Removing uterus should be last option and not the first one. Hysterectomy on demand should not be entertained, and do evidence-based counseling. Don't create phobia for uterine cancer. Decision to do hysterectomy is in the domain of gynecologists, not the surgeons. The take-home message is that the need of the hour is to come forward and support the campaign for better health of our women and families. Thank you.
In keeping with the flow, we will request Dr. Sapna to speak, followed by Dr. Thelma Narayan, and then Dr. Balu, and we'll break for tea post that. I would request you to please stay on. There's a photo session as well, and we would request you at that point to gather at the steps later on. We'll announce it again.
Hello, am I audible? I hope so. Good afternoon, everybody. I hope I'm audible, and please let me know if I'm not, and that you can see the screen.
You're audible, madam.
Great, and you can see the screen fine? Great. So I'm very, very sorry that I'm not there in person today for our 5th roundtable. We've really learned so much in organizing these already in the 4 previous states. Unfortunately, on the way to one of our roundtables, I fractured my foot in great excitement, clearly. So I'm very sorry again not to be there with all of you. But technology at least allowed this to happen. So before I begin, Narendra had earlier given a bit of background on how the data made their way into NFHS. And I just wanted to highlight, we are the only country in the world in which a demographic and health survey even collects data on hysterectomy in recognition of how serious the issue is from a public health perspective. I had first done public health sort of epidemiologic studies on hysterectomy in Gujarat in about 2009. And those numbers were troublesome, but it's only when we could get a sense of the national patterns could we really use that data, not just for advocacy, but also for informing the guidelines, both at the national and the state level. So what I'm going to do is give you a brief overview of just what the data looked like, both nationally and specifically in Karnataka, which hopefully will give a sense of where trends are going in the state. So as we see here, you'll see what the first map, which should be on your left, it's the national patterns from NFHS 5, which is in 2019. And this is the prevalence of hysterectomy amongst women who were 40 to 49 during the survey. And the reason we focused on this age group is because that's the age group that is really aged into the cohort. You expect women to have had hysterectomies already. And as you can see, Karnataka is not one of the highest prevalent states. The high prevalent states are highlighted in orange there. So it's Andhra, Telangana, Gujarat, Bihar, and now recently Ladakh. The map on the right, though, also gives you a sense of data of what we've seen in older women. And this is really concerning, but very interesting. So in Karnataka, amongst women above 50, 15% of them had already had a hysterectomy. So what we can deduce, and this is really not based on direct data comparisons, but just gives us a sense that it might have been slightly higher earlier. And it'll be interesting to hear from all of you if there has been some sort of introduction of alternative treatments that may have contributed to a slight decline in the state. But as you can see, generally, I mean, we do have pockets in the country where it's really concerning, up to 25% in Andhra and Telangana, for example. But as you'll see, as I'll present in a minute, the Karnataka data also do show some concerning trends. So this is the national picture. You see where Karnataka falls vis-a-vis the national average. The national average is about 10%. So 1 in 10 women by the age of 50 nationally will have had a hysterectomy. And it's slightly lower in Karnataka. Now, if I look in here at the age-specific prevalence, and this compares both NFHS 4 and 5, so it also gives us a sense of changes over time. There's actually been almost no change over time in Karnataka between 4 and 5, the 2 rounds, and frankly, nowhere in the country has really changed. But what is really concerning, if you look at the last 2 bars on the right, you see the median age. So the age at which hysterectomy was conducted in women is in their mid-30s. So we're talking 36 years old, which is essentially at least a decade before natural menopause. And in India, generally, it's not the prevalence that has, I mean, the prevalence is very important and it's been of concern, but it's really the low age that has really made people sit up, because women are getting hysterectomy essentially in their mid-30s. In other parts of the world, we've seen this happen much later, usually right before menopause or after. But in India, we're seeing it much younger. And for the trends that others have already discussed, the sense of, well, maybe the uterus isn't needed, or the fact that people want to get rid of menstruation, and also this sense of, you know, just go to the final treatment rather than doing follow-ups, which has led to this very concerning pattern in the country. Now, if we look at the district patterns in Karnataka, this is where you'll see some serious concerns, because there are 4 districts where you have quite high prevalence here. I'm sorry, I'm just trying to move this so you can see it. I hope this is visible now. So if you see, there's 4 districts here, one including 1 in 4 women essentially have already had a hysterectomy by the age of 50. So we see very high prevalence in these 4 districts here. And if there are participants here from these districts, it would be great to hear from you after in terms of why this may be, what we've heard in other states, such as Telangana and Andhra, states that have such high prevalence. It's just become the norm. It's become the norm of treatment, as well as the norm of understanding amongst both doctors and women of how gynecologic morbidity is treated. Now, if we look at the self-reported reasons, and this also speaks to Dr. Gopal's question earlier as well. So these are women's self-reported reasons as to why they felt that they had had a hysterectomy. Excessive menstrual bleeding is the #1 leading reason for why women have reported that they went to the doctor in the first place to have a hysterectomy, or they were given a hysterectomy. The second leading reason in Karnataka is cervical discharge. This also speaks to Dr. Hema's point earlier about the importance of really expanding screening amongst women for cervical cancer. So discharge is not seen as something that needs to be a reason for fear, a fear of cancer, or fear of other greater infections, which in most cases, all of these are amenable to basic alternative treatments that are non-invasive, medical treatment, etc. The third reason here is fibroids and cysts. So again, women are getting hysterectomies in the country. It's not to say that this is that it's correct or rational, but rather the actual reasons why they're undergoing hysterectomy are very problematic because it's basic gynecologic morbidities. Except, symptoms of bleeding, cervical discharge, and fibroids and cysts are really what we see leading across the state and across age groups as well. Now, if we look at the factors associated with who's at greater risk, and this is, from a multivariate analysis, but getting a sense of who's really at risk of having a hysterectomy in Karnataka, we see, women as they age through, and we know older women because that's after they've completed their families. The really, I think, important ones to take note of are women with lower education, and women in rural areas have higher odds of undergoing hysterectomy, which also is, again, a sign of the fact that the most vulnerable are also undergoing hysterectomies at a young age. Likely, many of them are unindicated, and they're the most vulnerable and have the least access to the health system. Of course, women who've completed their families is what we've known from patterns. And lastly, women who have not already been sterilized have a lower odds. So you sort of see this interaction between sterilization and hysterectomy, which we're seeing play out differently in different states to try to get a sense of, is hysterectomy replacing sterilization, or are women who have had sterilization undergoing hysterectomy because they're used to surgery? And that pattern plays out differently. And I suspect it's not a state pattern, it's probably a district pattern. Now, where are they getting hysterectomies? You see about half of them across the state of Karnataka are in private facilities and half are in government facilities. This is interesting because the national average in private facilities is a bit higher. So you are seeing much more use of the public sector in the state. And where, in terms of urban and rural, in urban areas, you're seeing a little slightly higher use of private facilities, but not really. It's pretty much the same, that you see the same pattern in both urban and rural areas, which gives you an interesting sense of access issues. And if we look at wealth quintiles, if you look at the bottom bar, the lowest quintile, which is the poorest population, have slightly lower use of the private sector and higher use of the government, as we would expect. And then as you go up to the wealthiest quintile, you see much higher use of private facilities. Interestingly, this pattern did not even play out in Telangana and Andhra, where everyone was using the private sector. So it's important to see this mix has been retained in Karnataka, where at least the public sector is still being used across the quintiles. And as expected, amongst the wealthier, they're probably not using it as much as private facilities and paying out of pocket. Dr. Shashikala had mentioned this, and I just wanted to highlight that from the LASI study in India, which is the first study, the only study that's nationally representative of women over 45, the first one in the country that was done in 2017, we did an analysis, colleagues and I, to look at what is the relationship between hysterectomy and other NCDs. And we found that women with hysterectomy had higher odds of hypertension, of diabetes, and bone and joint disease. Now, when we take this correlation in India with in the context of data that have emerged across the world now, where there have been long cohort studies amongst women, it's really been a very consistent pattern in the data that women who undergo early hysterectomy in particular, which is what we see across India, which is, before 40. So women who undergo early hysterectomy and are having their ovaries removed have a much higher risk of all of these NCDs, plus, as we've seen in recent data in Sweden, also mortality. So the risk of the unnecessary hysterectomy in of itself is problematic, and of course, all of the immediate side effects, but we're also putting a generation of women at risk of a whole host of non-communicable diseases and lifestyle issues that they will face, for example, with pain and bone, etc., that will last them through the rest of their life, well before menopause. Now, lastly, I'm just, for a bit of context, wanted to look at the C-section and sterilization data in the state, because this is often a question that comes up. Is this a surgical access issue? And what we see in Karnataka, as I'm sure you all know, that the C-section rate is slightly higher than the national average. So almost 1 in 3 births of the last births women underwent in the last 5 years were by C-section. So it's quite high, fairly similar in urban and rural areas, though a little higher in urban areas. And female sterilization is the #1 sort of use of contraception or method of contraception in the state. And that's actually even higher than the national average. So 57% of those using modern methods have been sterilized, which is important as we look at the method mix in Karnataka here. As you look at these bars, you'll see the green, which is sterilization. What we learned in Assam, for example, is it was very high use of contraceptives, of oral contraceptives, and they actually had quite a low hysterectomy prevalence. And one of the factors that was raised was that perhaps as women were being offered different forms of contraception, so like oral contraceptives, which may actually control bleeding, but also there was a readiness to accept other forms of methods like IUDs, for example, as well, which later have benefits for them vis-a-vis things like excessive menstrual bleeding. So looking at the MCPR, it's important to think of sterilization as an indicator of what is to follow, which is why it's, again, of greater concern. So I hope this gave you a brief overview of patterns in the state. But if I were to look at the state in comparison to the rest of the country, what we see is there's obviously districts that are following the same patterns that are quite worrisome in Andhra and Telangana. And this is really something as we continue to monitor both the data as well as the reasons for why women are undergoing hysterectomy. It'll be very important to keep close track on through, of course, the state committee as it gets set up. And just a last, in closing, I'd like to highlight the IAC committee. If there are specifics, I'm working with that committee. So if there are specific messages or things that people here feel should make their way into the IAC, please let me know on email, on chat here, or to Dr. Narendra there, so we can ensure that we can do our best to incorporate those. So thank you very much.
Any questions for Dr. Sapna?
Sapna ma'am, I have a question. Ma'am, you have done excellent analysis regarding the LASI study. But I think, ma'am, in that study, it was not reported when the hysterectomy is done and when the onset of diabetes and hypertension. So maybe, ma'am, we required more information or maybe more study before like any conclusion, like if we know the onset of hypertension, when at what age is developed, and then when the hysterectomy is being done. So then only I think the link may be, because I have also seen that data in the LASI study, and the exact age is not mentioned of hysterectomy. Am I right?
Absolutely. And thank you so much, which is why I specifically use the word correlation, because we didn't know the causality. But when we look at it, there's two things I'll say. One is we did try to do an interpretation of when, because we did have the onset of some of the other issues. So looking at the average age of hysterectomy, we could assume, but we didn't make that definitive conclusion because you don't have the temporality, like what happened first. That said, when we look at data from everywhere else in the world, that pattern has been quite firmly established in terms of women with hysterectomy. But now that you say that, we have put in a request to IAPS very, very strongly. And ma'am, it would be great to have your support from the DGHS to also say, please add the question on when the hysterectomy was conducted, because it'll be very important to understand what's happening with women's health in the country. So we have asked, IAPS was one of my co-authors on this. So we have asked very, very strongly, but ma'am, with your support, hopefully we'll get that question. But you're absolutely right. Yeah.
Sure, ma'am.
Dr. Sapna, there's a question in the chat box from Dr. Gopal. Can we have this PowerPoint?
Absolutely. I'll just send it. I'll send it on email now.
It's already with us, I believe. So with your permission, we would then disseminate it to the participants on
Absolutely. Absolutely.
Thank you. Any questions?
Yeah, Dr. Sapna Desai, madam, it was a very beautiful presentation on the data of hysterectomy and things. But I just wanted to know in your data, do you have whether the hysterectomy is done by a surgeon or a gynecologist? Because that data is also very important because we do come across when we come, post hysterectomy, people coming with symptoms, and then we really go into the things. Quite a few of hysterectomies are done by the general surgeons. So do you have any information on that in your data?
Thank you for that excellent question. This is something, again, has come up in every single roundtable, which is, of course, is who is doing the hysterectomy. And the NFHS, the national data do not collect this, but I'm currently doing a study that's funded by the DBT Welcome that's looking at hysterectomies in Andhra, Telangana, Bihar, and Gujarat. And we've been trying to add that question. And interestingly, and it'll be good to hear your opinion, we wanted to add a question on who did it, but a woman rarely will know who actually conducted the surgery, whether it was a surgeon or a gynecologist. So we are looking at proxies. So to ask her, did you undergo a pelvic exam? Did you get histopathology? Were there lab tests done? We were trying to see if we can devise proxies, because what we've been told, at least the patterns in these states, has been that there's two sort of referral pathways. One is when there's an RMP directly to a surgeon, and then there's when you actually see a gynecologist. And then even if a surgeon is involved, but the gynecologist has really decided that the hysterectomy is needed, etc. So we've not been able to get that data. And what we're hoping is, as Rupali ma'am had shown earlier, the audit forms for each state and district include that they have to tick who did the surgery. So though we don't have that at a national data level, hopefully the audits that will now start happening with the new guidelines will include who did the surgery. I mean, that is a requirement. So only after that first round of analysis, we'll get a sense of what proportion of surgeons versus gynecologists are doing this. And our understanding is there's a high proportion being done by surgeons.
It might not be sort of a clinical question that I would want to ask you, maybe connecting to the previous question also. From your graph, it showed that Telangana, Andhra, and now probably even Karnataka heading towards that of accessing private sort of facility in terms. So the previous presentation was mostly about engaging the village health workers, Anganwadis, A&Ms, and then so how good it would do. I come from a community health or a public health perspective. How good would it do if we sort of make these village health workers robust, if people are accessing private healthcare, first point? And if they're accessing private healthcare, is it not mandated that sort of a video or something recording is being given to the patient vis-a-vis prior public? I can understand they have to maintain register, but most of these procedures have to be recorded, and then a copy has to be provided to the patient. So that should give us the record who has been doing these procedures. So I mean, I'm trying to find the links. And then the reason for accessing private healthcare, is it affordability? Is it accessibility? Or is it trust or sort of promotion that the private sector does, or lack on the public health or the state on unnecessary hysterectomies? I'm just trying to connect the dots given the previous presentation and your sort of data that comes out.
No, absolutely. And I think that is the crux of our challenge. The fact that, in the states where it's very high, and even in states where it's going towards that. Sorry?
No, I just said that the person who asked the question could introduce himself also.
They have the mic?
I'm Prafulla from SOCHARA.
Okay. That's good to speak with you here directly, Prafula. So I think you hit the crux of the issue when it comes to the public and private. I mean, what we know from the other states is that this is largely happening in the private sector, though in Gujarat, for example, 1/3 are also in the government. Two things. I think the audit forms by design are supposed to be all facilities conducting hysterectomies. So it'll be up to these district committees that are formed, which are chaired by the district government officials, but with them should be doctors from the private sector, as well as development partners and local community-based organizations, to actually try to get these data from the private sector. Realistically, we know that is going to be a major challenge in terms of how do we ensure that all private facilities are actually recording the hysterectomies they do, and that'll be up to hopefully local accountability and sort of the advocacy push to ensure we get these data, because until we actually see what's happening in private sectors. The second point, and something around the village, like the health workers, for example, are doing local awareness raising, is hopefully that women start to understand that there are many, many options. What we've been understanding as we've been going to different parts of the country is that women are completely unaware that there are other options because they're not being presented to them. So if there's a sense that, I don't need to get a hysterectomy for bleeding, and that you actually have these 3 treatments like an LNG or hormonal treatments, etc., available, and those treatments are available in the government system, that should be an alternative treatment pathway that is created. That should hopefully start making a break in the fact that women are going straight from an RMP to a private surgeon, for example, if that is the pattern. What we do know, insurance, there have now been a lot of brakes put on how insurance can be used in the private sector for hysterectomy. So the women who are actually getting these are paying out of pocket for the most part, and largely probably going into debt. So that's another issue, that if we can create these alternative pathways through the public system, through primary care, to ensure women can access basic gynecologic treatment, that would hopefully be where we'll see these patterns change over the next several years. But I don't know, if there's other ideas you have or suggestions, it would be really important to hear them as well, please.
So in addition to what Sapna had said, that if you want to know who had performed hysterectomy from this data, now, as I said, that every hysterectomy has to be reported in the proforma, which has been now drafted by Government of India. And that will go to the national portal, and then ICMR will also analyze the data, as Dr. Roy had said. So once that data is available, we would certainly get to know whether the hysterectomy is done by a surgeon or by a gynecologist or anybody else. That would happen. And within that proforma now, you have to, a person who is performing, the doctor who is performing hysterectomy has to give the reasons why the hysterectomy is being done. And in case that he has given certain indication, in support of that, if there has to be a biopsy, that histopathological test also is required to be done. So if that proforma is strictly, enforced, then certainly these hysterectomies which are unnecessary ought to come down. That is the whole idea, and under which all these things are happening. So this is what I just wanted to say in addition.
Dr. Sapna, I understand from NFHS, it's difficult to probably find out which particular community is in Karnataka, in those districts especially. Is there any particular community which you've heard of or known of that has the number of hysterectomies? Or is there any particular, like suppose there was a few years before, I think garment workers went through a lot of hysterectomies because they were clocked on time and things like that. So is there anything of that sort which was noticed? Is there any data on that?
Thank you for that question. No, the data right now that we have from the national surveys are largely the geographic clusters. Unfortunately, the NFHS at this level of women doesn't have all of the occupation data. So that's something we're now trying to study in the new states where we're working to get the actual, in which informal economy sector that they're in, what is their work and occupational sort of security around it. When I worked at Seva, for example, we knew it was agricultural laborers for the most part, for the reasons, and Narendra had mentioned earlier, we found in Telangana, there was women who were working in the turmeric fields and haldi fields that felt there was an issue. So there have been these sort of anecdotals around different occupation groups, but from a data point of view, no, we don't have anything except the geographic clusters. I do want to highlight though, rather than focusing on specific occupational categories, I think it's really important to just remember that these are the most vulnerable across the country. So it's women with less education and women with less access to healthcare. So a lot of the solutions will lie also in ensuring that that access to healthcare is strengthened and also awareness on both sides, in addition to the strong monitoring and audits. Because a lot has been made in the media, for example, of certain categories of workers. And what I fear with that sometimes is the disservice it does to the larger public health issue, which is this is really about access to gynecological care for all women.
Thank you, Dr. Sapna. We will next have Dr. Thelma Narayan to speak to us about public health and women's health perspectives. Dr. Thelma Narayan is a graduate of St. John's Medical College, as well as former faculty member of the Department of Community Medicine. She also has a specialization in epidemiology and a doctorate in public health policy from the London School of Hygiene and Tropical Medicine. She co-initiated the Community Health Cell, which subsequently was registered as the Society for Community Health Awareness, Research and Action, SOCHARA, in 1991. This functions as a professional resource center in the voluntary sector. Dr. Thelma is also part of the People's Health Movement, has been part of the People's Health Movement, and has also been one of two organizing secretaries for the 5th National Bioethics Conference and the World Congress of Bioethics as a participant. Over to you, Dr. Thelma.
Friends, I know it's late and everybody is probably tired and hungry. So we'll keep it very brief. One is that I think the presentation so far has shown the important role of different professions within this, it's a societal issue, the issue of hysterectomies, unnecessary hysterectomies in particular, and also women's health, if you look at it. So I think the role of public health and in this case, obstetrics and gynecology sort of intersect very closely. And the data that have come and the demand for data is also something that public health has contributed. I would say community health is an approach to public health where the active role of communities, here the women who are actually undergoing hysterectomies, what do they feel about it? What do women in general feel about it? What is their voice actually heard? Or are they just patients who are subject to, professional sort of enterprises? So as we know, public health aims to protect, promote, and restore population health through organized systematic efforts. So it is societal in scope, and it involves every stakeholder in society, and therefore tries to create a conversation across different groups. Now, there'll always be tensions between all these groups. So when the state says do this, monitor, or there'll always be a resistance from the professions. There'll be probably resistance from communities also. And how do we negotiate these areas of resistance? Because we tend to focus only on what we are interested in, on what we are trained in. So I think the scientific approach is actually to be open and to really keep our minds and question ourselves, are we really open to listen to other people, including the women themselves? And it's not that women are not saying what they have to say. So I think public health ethics is something that tries to bring the greatest benefit to health and well-being of populations while attempting to minimize disruption of individual rights and autonomy. We talked about dignity, human dignity as being basic, from wherein flow human rights, the fundamental human rights which are inalienable. So this is where I think we have to ask deep questions of ourselves. Maybe at the end of every day, could I have done something differently today? Could I have spent more time with this patient? Was my interaction, was I really listening to what that person had to say? Was I listening to the body language? Was I listening to what she's doing, what occupation she's doing, etc., etc.? Now, we may say we are too busy, but then does that not raise an issue about our health system? How do we plan our health system? How do we run our health system if we are not spending enough time? Then everybody just becomes a sort of a cog in the wheel. You may say another tick box to be ticked off. So I think focusing on these basic principles is where I would like to focus. So women's health, women themselves, this comes from a women's health empowerment program, which we were part of actively for many years. And where there was a very good cartoonist who said that there's more to me than my womb. I'm a person, and is there equal status even between women? So as professional women, we are much more privileged as compared to women who may not be that educated or who are under pressures of agricultural labor or unorganized sector labor. So are we aware of that privilege? So I think the People's Health Movement or the Jan Swasthya Abhiyan had come up with a framework for women's health, the Women's Health Charter, way back in 2007. There were lots of consultations, and women's right to health and quality healthcare. The state's obligations to protect and promote, and we can see the state has made some efforts, but I can tell you, when you go to the ground, and many of our team members work on the ground with communities, we can't see the face of the state at that point of time. It's sort of absent. So it's a good intention, and the intention is good, and we are here to support that direction. But let us tell ourselves very frankly that what happens on the ground is very different to what we say in, women do not have an understanding. In our program, we asked women to whether they knew what the uterus was. They had no idea. We took little bits of atta and got them to make, designs of, all sorts of weird things came up. They had no clue where the uterus was located and what caused bleeding. So what we take for granted in anatomy, physiology and things, many women have no idea as to what it is. So I think some attempt to, and there have been institutions in Gujarat actually who've come up with the models of the uterus, and we've used it extensively in training. So even getting women to understand what happens and what are the processes, then they can be part of decision making. So, so when we do laws, policies, and programs, they may reach the direction we are attempting to reach, but there's every possibility it may not. So while we look at data, we also need to look at social processes and keep a tab on what's happening to those processes to document it as rigorously as we document, the data. And I think the epidemiological data which Dr. Sapna provided was really fascinating, extremely well done, and very, very informative. So when we talk of violence against women, there are some people who feel that actually unnecessary surgery is sometimes also a violence. It's sometimes the word surgical mutilation has been used. It's a very strong word. Most of us doctors would find, ourselves cringing about it. But let's not, let's think about it. The social determinants of health underlying unnecessary hysterectomies, I think some of the questions that were raised about occupation, garment workers, and agricultural workers, turmeric field workers, etc., is a very important issue. And so social scientists and others also play a role in all of this. So also, what about access to care for women with special needs? So these are the factors affecting women's health: overwork, poor nutrition. We know this. And we will, I think not, I know everybody's tired, so I'll just try to mention the issue of financial pressures that women are under, which forces them sometimes to do this. And what can be done to address that? Poor governance of the health system, the accountability mechanisms within the health system. You know, how can they be strengthened? We have them. I've been part of committees in the advisory group on community action for health, the village health and sanitation committees. There are lots of proformas there also. And I can tell you proformas don't solve the problem entirely. So we need to have social processes, human processes. I think mentoring, which will be coming up later by Dr. Balu, is one such possible process. So these interconnected rights, which India has actually signed on to right to health and healthcare, universal social protection. In the Universal Declaration of Human Rights, way back in 1948, we had signed this. CEDAW, the Convention on Elimination of All Forms of Discrimination Against Women, 1979. The Child Rights Convention on Rights of the Child, 2013. So you have many young girls who are also influenced and affected by what we have been discussing. So the signs of hope are what you've heard already, including policies and statements. The Karnataka state has a task force on equity, quality, integrity, and care. The state health policy. Then we have the policy concerns were about women as a whole person. The life cycle approach was discussed, empowerment, community development. Male participation in these decisions is also something that needs to be addressed. Most men, the women don't have much idea. The men have even less about where the uterus is and what it does. And I think they should know. So we need to make every effort to make sure that our health services are gender sensitive and women friendly. When we tried in the task force to get the health services to have gender training, gender sensitization training, the police department accepted gender sensitization training, but not the Department of Health. You know, so these are our actual experiences. So women form half of humanity, do 2/3 of its work. We earn about 1/10 of the income, and we own only about 1/100th of the property. So in this case, I mean, when you see what is the decision-making role that a woman could play, then it has to be in this context. So the challenges are where we can offer women a better world, where we are heard, where women matter, and especially women from less privileged socioeconomic backgrounds for education, and where there is a greater, sort of sense of solidarity across all sections of society. That's what we're working. We are not into an accusatory mood. We are not putting one against the other, people against the professionals, but actually working together. So again, we end with, there's more to me than just my womb, my dignity, personhood, and reflection by all of us. Thank you so much.
Thank you, Dr. Thelma. I would like to invite Dr. Balu, PS, to speak about data-driven mentorship program for reduction of unnecessary hysterectomies. He is currently the director of the Center for Digital Health, Artificial Intelligence, Research and Training at Basveshwara Medical College and Hospital, Chitradurga. He is a public health specialist with more than 20 years of experience and holds an MPhil in hospital and health system management from BITS Pilani. Dr. Balu has been awarded the prestigious Shri B.M. Patil Ration Award 2017 from the Karnataka Association of Community Health. He is the chairman of the Zonal Task Force South Zone, part of the National TB Elimination Program, and has also contributed to capacity building of the private sector in TB treatment and care. He serves as the president of the Association of Public Health Technologies.
Okay, thank you. I know it is late. You're surprised seeing my profile. I work in TB, and I was also surprised when I got a call on this particular topic from my friend, and I spoke to Madam on this. But yes, we work mainly in digital health and AI in relation to women cancers. So I'll be sharing some of the experiences, best practices which this program can take from the other work we do. See, when I look at this guideline, well-drafted guideline, congratulations for whoever has drafted it. I'm going to look at this document more in public health angle. Okay, so because this document looks at uterus as single, but for me, it's 2.324 crore women in the state of Karnataka, whom we have to be reached in order to ensure, as per the title of this particular roundtable, to reduce gynecological morbidities first, and then I'm also not so keen on unnecessary hysterectomy, maybe evidence-based promotion of evidence-based hysterectomy. Yeah, this unnecessary hysterectomy, sometimes as a doctors, we feel sad. It's blaming our own doctors. Yeah, that's happening. So I've split this into two parts. I'll quickly finish this. The first one is a project which we are doing, not this, but this is the name I thought I'll keep for this, because you're looking at also addressing gynecological morbidities. Unless you address gynecological morbidities, you will not be able to prevent hysterectomy. Means you need to reach the woman very early, identify the symptoms, so that whatever sir and everyone has spoken about, alternatives available for hysterectomies are made available and ensured that they don't land up in surgical procedure. So that's what I call, how do you support access to gynecological assessment in rural areas by using e-health and AI? Dr. Hema Devakar Madam spoke so well about how can we use technology. So I feel AI and digital tools can definitely help. We have our own experience in CS cervix breast cancer, where it has shown to be highly impactful. The second part of my presentation will look at how do we reduce or how do we promote evidence-based hysterectomy, or as per the title, how do we reduce unnecessary hysterectomies? How do we identify the sites? Because when I look at Karnataka, what we are looking is roughly 2,906 healthcare facilities in the government. I'm taking this data from the government setup. This is the number we are looking. And when I look at private sector, which are empaneled, there may be many, but approximately 550 private sector hospitals. So we need to be very, very cautious and careful in looking at how do we select the sites, how do we generate the evidence, and so that we spend whatever time and advocacy we can do to these specific sites rather than taking it all over the state at one go. Okay, in addition to this, what I'm also looking is 9,285 health and wellness center. Dr. Hema Devakar again mentioned they are doing a program of women awareness through teleconsultation. So how do we reach this health and wellness center? I've just used the recent term which have been coined as Aishman Arogya Mandir. Most important for me is how do we reach these 6,000 gram panchayats? Because the document mentions various stakeholders who needs to be trained. And when we are looking at public health and community angle, gram panchayats play a very, very critical role. So my focus will be on some of these in the initial 3-4 slides. This is the woman group we are trying to reach in the villages. Now, the question is, how do we reach them? So that is the big challenge. So many 2.6 crore women approximately, if we look at the electoral vote. The best thing happening in the government is already doing an annual survey, which the document mentions, which is called community needs or community risk assessment form, which are done through ASHAs. What you're seeing in the blue box is the one which is related to breast cancer. On the other side, what you will also get is all the data related to menstrual issues, all the data related to whatever your guidelines is looking. So this is an annual survey which is already done as a part of NCD program. Let's not look at quality issues, but yes, there is something happening in the grassroots level where ASHAs are already trained. This is the actual photo, what you're seeing. We use this data for breast cancer screening. When we go to the field, we ask ASHAs to pick and bring all those women whom they have identified. So the yield of your cases goes up and you pick right number of women. So I think this is one of the areas where the program can look at because I feel you already have a data. Now it's our job to find out where and how this data is getting consolidated, right? From the field, it comes to the PHC to the district, district to the state. That means in the last 1 year, we already have a village-wise data of women who may be suffering from abnormal menstrual problems. There may be white discharge. We already have a data. Whatever quality, let's not worry. We do have data. So good to look and see where is this data getting collated so that you can immediately extract it and see where are the pockets from where these we can focus on, you know. But this is one aspect which I thought I'll share as a community-based approach we need to look. The second thing which the document mentions, the national guidelines for unnecessary hysterectomy, is when you find a woman with whatever the symptoms they have listed, you take them to the health and wellness center where the CHO will refer them to PHC. And then if the PHC medical officer wants, they can schedule an e-consultation. Now, my question is, why do we have to wait for a woman to go to PHC and from there again, if the medical officer has to take a e-consultation, why don't we schedule the e-consultation directly? Because anyway, CHOs have access to e-Sanjeevani platform. They can schedule the consultation immediately because it saves time. Because I believe once you refer a woman from village to PHC, she will never go, right? There is travel cost involved. Again, you lose that particular woman and she may end up with a problem at a later stage. And this is good. E-Sanjeevani is one of the tools which is already available, which CHOs are comfortable. So why don't we use it? The other thing which I'm proposing in addition to, you know, directly linking with the gynecologist is I'm making this presentation specific to Karnataka because the title is on Karnataka. Karnataka is blessed with medical college in all the districts. We have OBGYN departments in all these medical colleges. We have sufficient number of PGs who are available in the medical colleges. Can each district, we do advocacy, and government colleges can easily get into the e-Sanjeevani platform. Private, they may not allow, but yes, the government doctors working in the colleges can get a common ID. Whoever is the PG posted there in the OPD, he will take a call. How many calls we can expect in a day? I think it will be very less. We need to try this approach where existing system can guide rather than woman going to PHC to the gynecologist. And I think gynecologist is the right person to guide that particular woman because she can ask other questions also. We are not just looking at hysterectomy. She may have some other problem. Why don't we create a complete woman health approach, taking hysterectomy as an entry point? Okay, so the next thing which we have done that, whatever you saw the teleconsultation, we have done that. The next thing is you have to reach out to the woman, roughly 2 crores. And the best way to do it is through the Gram Panchayat. The reason is Gram Panchayat, 1/3 members are women. Okay, they are the policymakers. They are the advocacy members at grassroots level. From the TB program, we have done it. We have trained the entire Gram Panchayat. Okay, and the Gram Panchayats, I believe, already have a task force, that is Village Health Task Force, right? Now, that was formed during COVID. Now, why don't we use the same task force to look at monitoring or whatever you want to call in relation to women's health or hysterectomy? So we have around 6,000 Gram Panchayats. What I'm looking at 1/3 is you need to reach 30,000 members. That's very, very huge numbers. And if we look at cascade kind of a training, it is not going to work. So the solution is let's use the same thing which has been used by other programs. There's a very good administrative training institute in Mysore where we have the RDPR training center also. It has a very good video conferencing facility, and you can reach out to each and every gram panchayat at one go. But the question is, the people who are experts need to decide what do you want these gram panchayat women to do. Let's not go back and sensitize them on theoretical aspects of hysterectomy, but what role they are going to play if they are going to be sensitized, and what is the other things the gram panchayats can do to make their women safe, not only in relation to hysterectomy or entire women's health. So look at this, it's an interesting area. We have done it in many programs. I remember in the same hall we developed 15 years back for HIV. With St. John's only we did that entire outreach. Yeah, a lot of support also from the government. See, the other thing we need to look is, since morning, even Madam also presented, the HOD from St. John's. I think I also saw the data from Dr. Desai's presentation where she showed people, women with hypertension, diabetes had higher risk or underwent hysterectomy more than who didn't. Now, I'm little surprised, but still, what I thought is, because your guidelines mentions that you need to screen this woman, what is the option we have got? Karnataka has got a very good program running in, I believe, 10 or 15 districts. It's called Gram Panchayat Amrut Arogya Abhiyan. Now, as a part of it, what they do is they mobilize all the diabetes, hypertensive, high-risk people to come to this camp and do the screening. Now, if you are looking at linking your program, I think you have an opportunity. Already women are coming. The CHOs are posted officially there. And if you can collect this data from them very accurately. Whoever is the woman coming, you give them additional 4 questions, so they will be able to collect and refer. So the whole idea is to look at identifying women early within the existing system and programs, so that we don't reduplicate our activities. And I think 10, 15 districts, whatever the districts which they showed, 4 districts, they showed higher number. All those districts are having this program. I believe Mandya may not be having, but I'm sure all other districts have this. Now you have good health systems support. We have a good MD, principal secretary. We have good additional chief secretary. So if you are looking at engaging RDPR, maybe you need to look at having a meeting with them and see how do you engage the RDPR and Gram Panchayat women members in addition to your health. Because the reason I put this photo is, in the entire national guidelines, there is a just mention of stakeholder, but who is the stakeholder whom we are going to engage, and how it is going to be engaged needs to be properly rolled out. The other thing, what I was looking is communication. Since morning it is coming up, how do we communicate to 2.6 crore women, right? It's not going to be easy. Setting up a toll-free number, I don't think it's going to work. We have so many toll-free numbers. How many of us have called, right? It is just doesn't going to work. One of the models I want to share here is the model of TB, which was done by KHPT, right? Now, what they did was, any TB patient who got registered used to get a proactive call, just to say, hi, hello, how are you doing, right? Now, something similar can we do here? Can the woman, whoever is coming to the CHO or wherever, right? We set up 2 counseling hubs, one maybe in Bangalore, one in North Karnataka, where whoever is undergoing hysterectomy, you need to also call them for follow-up. So you can look at interesting innovations which you can do, rather than the toll-free numbers are good, but I don't think they could make difference. One of the interesting toll-free number we have our own experience was in the diabetes program. Now, how it worked is, once you give a missed call to this particular number, your phone number gets registered. Now, at a frequent interval, they planned it as every 3 days, a new message goes to the diabetic patient, right? If you are looking at behavior change, if you are looking at creating awareness in community, pumping messages will not work. Dr. Hima Devakar also told they give 40 seconds, 1 minute messages. So these are already innovation. IBRS, you just give a call. If you're looking at entire women's health or entire thing, engage them for 3 to 6 months and see how many times. There's no need for them to call. Automatically, once they're registered, it is predetermined and it messages automatically goes to them. Whether they see here or not, that's secondary. But yeah, you have an option. This was very interesting aspect which was done in diabetes can be tried here. Okay, now coming back to this question of your auditing. I'm really worried. How are we going to audit so many hysterectomies happening in the state? And two, who is going to do it? How we are going to do it? With so many centers, so many districts. One of the options I looked at, whatever the data was presented, I think was pre-Ayushman Bharat. Now with Ayushman Bharat being available, I'm sure most of the doctors who are here may be aware, hysterectomy codes are already there in the Ayushman Bharat portal. Now, if I have to do a hysterectomy, I need to put the code, and they've also given what are the requirements. Now, my request is, I'm not gynecologist, request is see whether your guideline matches with the prerequisites asked by Ayushman Bharat. That itself will reduce a lot of things. Two, why you want to duplicate so many things? There's already a data available in the government setup. Look at what is happening, who is doing the surgery, everything you can get. Ayushman Bharat will tell you who is a surgeon or a gynecologist who did this surgery, which hospital did it. So there is codes, please have a look at it. So I put 3 codes, but I saw some 5-6 codes on hysterectomy being there. Same thing you can also look at for your private sector doctors. Let me make it clear also here. Now, no patient in Karnataka can go to a private sector and undergo hysterectomy under the government scheme. As per the new ABRK thing, they have to go to the district hospital. District hospital has to certify they can't do this. Means it is a complicated procedure, then only they can go to the private sector. So that's why you keep seeing good number of patients undergoing surgery in government. One of the guidelines priority for you is less than 40, right? That is the area what the guideline is looking at. Every hysterectomy, but less than 40. Let's look. Let's see. Do you think this site needs mentoring? I just gave an assumption data because taking, let's say, a site 1, I took the data as 150 hysterectomies in 3 years, and your priority as per the guideline is less than 40. So in the same site, they did 10 less than 40 hysterectomy, which comes to 6%. Do you think this site needs to be mentored? Yes or no? How do you decide? All of you sleeping, right? Public health PSM data. No, this is very, very important because see what happens is we have limited resources. Now, how do we select the site? This is just an assumption. Okay, let's take 8 districts, site 1, 2, 3, 4, 5, 6, 7, 8. Now you put total number of hysterectomy done in that site. Then you also get data on how many less than 14, calculate the percentage. Now, once you do the average, 10% is the state average. Okay. Now, any site which is doing above the site average needs to be mentored. I'm not saying audited, needs to be mentored. Means it needs further look. Is it doctors who are there who are doing something wrong, or is it community preference? Because there may be chances that we may have to change the community behavior also, right? So this is easily doable in Karnataka. We have an ABRK system. Get this data and figure out which part of state you're getting these more than state averages. So let's focus on those particular pockets first, then moving on to other part. Okay. Health insurance, Madam has already touched. Again, you can look at, are they following national? Yes, ma'am. You want to ask question? Yes, ma'am. No. Let me come back to this. This is not incidence. This is I'm mainly looking at, the program is looking at less than 40. So my priority, annual. This is just an assumption data, ma'am, not real data. See, for example, if you have 8 districts, right? Karnataka has 2,000 hospitals. Now, if I have to mentor hospitals, I need to select some hospitals, right? Now, how do I select some hospital is based on your own criteria of less than 40. Take total number of hysterectomies done in last 3 years. In that, take less than 40. You get some percentage. When we do it for the entire state, you get some numbers. Okay, that is the state average. Anything above that needs to be focused. Otherwise, what happens is, let me say, if I see 7 individual number, as a gynecologist, it will tell me, a 7, let's leave it. But when I convert it into percentage, it is 23, right? So we need to look at doing this exercise and figure out where are we going wrong. I'm not saying doctors, there is also community preference. There could be many things. Once we have this data only, we can make out. Now, health insurance is one area, again, you can look at. Is it aligning with your national guidelines? I don't know. I'll just skip this because of shortage of time. My biggest challenge is we couldn't get data during COVID from private sector. It was so tough, right? Reporting SARI cases every day is difficult. Now, how do we get these? These are very simple, 8 or 9 questions, but it's so difficult to get from private sector. We need to see. One of the options is the Google Forms, which can be linked to every hospital. They just need to fill it rather than waiting for every month. This can be done, or I don't know how we are going to work out, because it's going to be very, very challenging, even for the hospitals to do it, because it's patients come and go. Histopathology report comes later. Sometimes patient will not come, right? And whoever is typing may make an error. So these issues are there. So my thinking is we should focus first on the government setup, look at what is happening there, slowly move into the private sector. Okay, last slide. Please include at all levels people from Ayushman Bharat. They are missed in the entire committee because I feel they are the right people also to give you data. RCH officer may not have data on hysterectomy. Again, he has to rely on the district ABRK coordinator. Instead of that, you can have at all levels these people. It will help in better coordination. And also, if you want to include some more clause in the hysterectomy, you can include it. It's also good everywhere there is a medical college, good to have public health people also, because once you are looking at audit, we are also looking at prevention. We are looking at community engagement. So it's good, if possible, to relook and see whether these two, or maybe there may be more, but that's what I felt good to have in the committee. So this is it. Let's put a stop to unnecessary hysterectomies and let's see where do we go from here. Thank you so much. Yes, sir. Hmm. No, sir, I checked. This private sector can still do it if the district feels it's a complicated case. Yeah, not all. They can't go directly. Yes, they have to go through the system. Yeah. Hmm. Yes, ma'am. Yeah.
Laparoscopy and his diagnostics laparoscopy mainly,
Yeah.
and the normal hysterectomy they are not doing. Are a big fibroid or a with staging laparotomy for those patients.
Yes, ma'am. No, madam. You can include the codes if you want. If the state feels there is a need.
They have no. There is no. They have given the code for
No, they have
our
given.
hospital.
That's what I'm clarifying.
Separate.
No, that's what I'm saying. If you think this code is required in that particular area, it is missed. You can discuss with the RBK. If they get convinced, they will do. It's not that codes can't be included.
Okay. Okay.
It depends on how are you going to justify. But for example, we got some TB codes included in the private also. In fact, if you look at ABRK TB integration, it's one of the best practice and documented. We spent nearly 6.7 crores something government spent on TB patients, right? And some of the procedures are in the private only. So that codes were available there. The problem, let me tell you what happens is the codes are department or specialty specific sometime, right? Now you need to check where does this hysterectomy go? Does it go under the OBG or surgery? What is happening? I don't know.
No, ours is separately. They have given the proper codes, sir.
What's the code? Okay.
Codes are there.
Yeah.
Only for our hospital, there's separate codes. I think so.
Yeah.
Because there is no regular hysterectomy. There is no code for us in
Okay.
Eichmann. Only the laparoscopy or the complicated or the staging laparotomy is there.
Sir, thank you for that elaborate analysis, and you have given the picture in Karnataka. I just want to know whether any initial study has been done to analyze the factors which are influencing the hysterectomy rates. And what I feel is they are different. The indications are different in a rural sector, in a district hospital, in a taluk hospital, in a tertiary referral hospital. Naturally, we expect more cases there. So whether a study has been done by the government to analyze these factors which are affecting the rates of hysterectomies and these unnecessary, whether anything has been done.
Government, I'm not aware. While
Analysis.
preparing for this lecture, I've come across many papers published from the state, which looks at all the factors what you're quoting. What I can do is I can send it across to Madam or SOCHARA email ID, and they can share it with the people who are here. I don't think government will be able to take up such kind of surveys, as it has to come from NFHS only. Yeah, for us, I think we need to look where are the pockets. For example, for TB also we have done this. High volume, medium volume, low volume gram panchayats. So we are focusing on high volume gram panchayats, trying to understand why is TB spreading there. Now, when you do a similar mapping, you'll definitely get, it's not entire North Karnataka, right? They told Bijapur. It may not be, I don't know Bijapur. Let me talk Davangere, my district. It may not be entire Davangere district. It can be Harrier. It can be some pockets. And even some nursing homes or some hospitals where this may be happening. Yeah.
Such study will guide us in putting the focus on public health awareness programs.
True.
We can focus more where hysterectomies are being done for
Correct.
less than 40 in some of the pockets.
Yes.
We have seen in some of the tandas, they have these highest rates. So there more public programs can be done. That's why I think this study is important.
No, that's why I told ma'am, in all the medical colleges, Karnataka has medical college, you constitute the district committee. There's no need for district committee. All the data can be extracted from state. If you sit with the state office, sit with the commissioner and MDNHM, if you are convinced, they will sit and ask the ABRK team to sit with you, give up to, you can get from which village somebody has undergone hysterectomy. It's not an issue. It's the way you look at it. I looked at today as public health perspective, right? The guideline looks at it as hysterectomy perspective. Somewhere that needs, that's why I put have public health and ABRK people also. Yeah.
Thank you,
And maybe pathologists. I didn't see pathologists also because they are the main. Somebody has to look. Yeah.
Thank you.
No, they will upload, ma'am. Somebody, when you're auditing, somebody should be there now. They will upload, ma'am. I'm saying your district committee, as per your guidelines, needs to audit. Now, when you want to audit, it's good to have a pathologist. They'll know whether sufficient section or whether sufficient interpretation was made or not. My thinking, but yeah, it's left to the people. Yeah, ma'am.
Thank you. It was a really very good presentation, and it's good to see how engaged the government is on these issues. I think you brought it up a couple of times, and as I've been listening to all the various speakers from the morning, I think Dr. Thelma has brought it up as well, that there is an issue of unethical practice in this. If the hysterectomy is unnecessary, then we are talking here about unethical practice. And therefore, the onus of responsibility really should be on the doctor. We have tried to look at it as a social concern, a government concern, a community concern, and so on. But a hysterectomy cannot happen without a doctor.
That's true.
Either recommending it or doing it. And so we shouldn't really flinch as a community of doctors. We really shouldn't flinch from accepting that this is our responsibility mainly, while everything else is coming in as guidelines, as codes or as, proformas to be filled in, audits and all of that, just because we as a community or fraternity are not really doing what is expected of us. So if we want to retain our own autonomy as doctors, we are going to have to really introspect and probably recommend as part of this roundtable that as gynecologists in our community, in our fraternities, in our societies as well, OBG societies, public health societies, and other doctor groups who are interested to really get into understanding that the responsibility lies with us. We should be able to apply some kind of peer pressure or maybe peer awareness that hysterectomy is not just an option, it is the last option. And we have to keep talking about it in that way. Sometimes we don't emphasize it enough, and possibly in our groups, we don't talk about it as being a problem. So then issues like conflict of interest, if it is the reason why doctors are doing unnecessary hysterectomies, or exploitation of vulnerable populations, as we heard all afternoon, this won't happen if we as doctors talk to each other and put the pressure on each other to really have to conduct ourselves ethically, to do what is expected of us. And our mandate as doctors would be to provide this kind of competent, ethical care. Once we lose sight of that, then all options are possible because the power is in our hands. We recommend the hysterectomy and we do the hysterectomy. So really brushing it off and saying it's a group thing or it's happening at the society and women and, empowerment of, development groups and government, they are all there. And they are very gently trying to tell us that we are doing the wrong thing. So I think that we have to, in such a round table, at least accept that our own fraternity is actually at fault and accept that. Once we accept it, we can then build it. We can have in our mortality meetings, morbidity meetings, discussion on ethics, ethical practices. We can have policies on hospitals on issues that have social concern like this. We can include them in our hospital policies. We can include them in our training of medical students and our PGs. And we can, at the grassroots, foster among us some kind of a better understanding of what is expected from us, and then work towards this as a part of the change. Thank you.
Yeah, one thing I also...
It says here, it's not been said here because there are not enough gynecologists here, so you didn't hear it. But the oft-repeated responses which you get is that if I don't do the hysterectomy, somebody else will do the hysterectomy. So why should I lose my patient? That's a common thing which you will always hear. We have been telling them, why don't you say that I'll not do unnecessary hysterectomy and I'll, through my association of whatever FOXY or any other association which we have created for ourselves, for our ethical conduct, not let others also to do unnecessary hysterectomy. Why don't you take that kind of a stand? But since we don't have those kind of people around here, so we couldn't discuss it amongst... Sorry? But I didn't hear from people. Those kind of debates, these kind of debates happen everywhere for that matter. Right. Yeah. So why we create FOXY or why we create these associations? We create these associations. These are professional associations for best ethical practices in our own profession and to guard it with all its might and strength. So if not only I do it, I don't do it, I'll not let anybody else also to do it, because then that person is violating what for we have created. We'll throw her out from or throw him out from FOXY if we come to know about it. And once we get to know about it, we'll audit as a group and see that this person is giving the bad name to our association.
No,
Shouldn't that be happening or not happening? Otherwise, you just hear this. If I don't do it, the other would do it. So why do I lose?
Yeah, one thing is the whistleblowing, and you're very right. We have to be whistleblowers among ourselves, and we should be able to speak up if we see something wrong. But the other thing is that all these societies I've seen, including my own anesthesia society, they are more interested in competence, developing their skills, learning more, sharing publications and journals, but they do not speak about health concerns that affect us, and also they also don't talk about ethics. I have always no.
Their data will be all useless.
No, I know.
They can't publish.
I'm just
if they
saying.
publish, that is a phony publication.
No, we don't have enough discussions on ethics within our societies. And there are a lot of ethical concerns, even in my society, with anesthesia, with end of life, with all of these issues we had. But they don't want to discuss that. What they want to discuss is the latest, tracheal tube or something else and so on. So competence and just improving your competence as a doctor or your skills is not enough. That's not what society wants. That's not all that it wants of us. It's the other half that's missing.
Yep. Mhm.
Correct.
So thanks for raising this. I think it should definitely go as a recommendation from our group. I know we're not the same group as we were a little while ago, but that's okay. That's the nature of such meetings. But I would strongly support that coming in. And because if we don't talk about these things, definitely it's our profession that's, end of the day, that's the...
Ma'am, just one thing, when the guidelines are for you also, I'm not sure whether all these drugs are there in PHC, right? The drugs, whatever you have mentioned in the guideline for managing, not sure whether they are there. Good to look at it. Yeah. Okay. No, that could be. No, I don't know. I'm not expert or done field, but my assumption is if those drugs are not there, it increases out-of-pocket expenditure, and the woman feels it's better to undergo surgery than spend 3,000-4,000 on drugs. Yeah, so that's one thing. No, sir, these drugs
Even in
can be
government sector, sir,
purchased.
if I advise a drug,
Yeah.
a simple drug, they think that why take these drugs for years together for 3 months, 6 months. Instead, I spend the same thing for a hysterectomy and get off permanently. So that's why I said, sir, we should emphasize on these methods, issues.
What I want to say is this, that now since it has got attention and with the issue of these guidelines, it's becoming more and more. And now there'll be pressure on states like Karnataka so far has not formed a state monitoring committee, leave aside district monitoring committee. So because now it's binding on every state, they have to do it.
That's
If
what,
they
sir.
don't
This
do it,
audit is going to bring out these factors,
right,
which are motivating women to undergo hysterectomy. What are the indications? So more focus can be given based
Right,
on the outcome of these
right, absolutely,
studies.
absolutely.
So that will tell us where to focus the public health issues, and public health programs can be designed accordingly.
Absolutely.
That's why this audit is important.
Absolutely. Absolutely. Bilkul. So do we close now?
These were concluding.
So, do we
Concluding, in fact, we already have completed this plan. I think you could say the word.
We thank everyone for making time to come here for this roundtable. We apologize for the extended time through this, but I think it's an important topic and we've had some very strong discussions. We will have the minutes recorded. We've rapporteured the event and also some note the concluding remarks that have been made. We thank everyone online if you are still there. And I request everyone now to just gather at the entrance, the staircase that's outside right next to us, the closest staircase. And there is tea available as well. And have a good evening. Thank you.